Iawn, bore da, a croeso i gyfarfod bwr iechyd Prifysgol Betsi Cadwaladr y mis Ionawr hwn, cyfarchion ar ddydd Santes Dwynwen, wrth gwrs, i bawb. Croeso i chi os ydych chi'n ymuno â ni ar-lein, croeso cynnes i chi os ydych chi yma efo ni yn Llandudno. Cyn i ni fynd gam ymhellach, dwi am droi at Lowri yn cyfieithydd, dim ond i wirio fod pob dim yn gweithio a Lowri eisiau rhoi unrhyw gyfarwyddiadau i gynorthwyo efo cyfieithu. Diolch yn iawn, Lowri. Diolch yn iawn, Lowri. Pawb yn iawn, popeth yn gweithio. Ie, pawb yn hapus o ran y drefn cyfieithu ardderchog. Un o ddau gyfriadau cyn i ni fynd i gorff yr agenda. Un ydy ffaith nad oes na alarwm tân wedi gynllunio. Os oes na larwm yna, dilynwch yr arwyddion sydd yn glir fan hyn ar gyfer yr allanfa a'r pwynt ymgynnull ydy tu allan ar y promenâd. Dyn ni falch iawn o groesawu rhai pobl ato ni. Bore yma, mae Jane Moore yn yma i gymryd dyletswyddau o ran iechyd cyhoeddus, croeso cynnes ato ni, Jane, ag mae gen ni cyfeillion o llais efo ni, a fydd Jeff yn cyfrannu at un o'r eitemau, croeso cynnes i chi, ac mae'n un o ddau o bobl eraill gobeithio yn mynd i ymuno, a dwi'n gweld cyfeillion o Archwilio Cymru hefyd, croeso cynnes ato ni. Mae gennym ni agenda lawn yn ôl yr arfer, ac mae gennym ni rhai ymddeiriadau. Mae Jason Brannan wedi ambell yma, croeso ato ni, George, diolch yn fawr efo ni bore yma. Ac dyna ni ymddeiriadau, os na unrhyw ragor o ymddeiriadau. Na, diolch yn iawn. Yr eitem nesaf ar yr agenda felly ydy datgan buddiant. Os gan unrhyw buddiant maen nhw'n dymuno datgan? Na, a fel dwi'n atgoffa pawb, os ydych chi yn cofio bod na fater ydych chi angen datgan pan dyn ni trafod rhywbeth, os gwelwch yn dda, tynwch sylw ato fo bryd hynny. Ymlaen felly i eitem 9.36 neu 1.3, sef cofnodion y cyfarfod blaenorol. Dion yna fel y rhai cywir, os gwelwch yn dda. Ie, pawb yn hapus, diolch yn fawr iawn. Yna ymlaen i'r pwyntiau gweithredu o hynny. Phil, anything on the action law you want to draw attention? Not necessarily reading all the action, but anything in particular you want to highlight, please. Gareth?
Sorry, I just got a couple of points of matters arising, if I may. They're not points of accuracy. So one was on 255.4, no, 0.2, sorry, which is about public health. And there's a reference there to the importance of diabetes in the current year. And I just wanted to underline how important I think that is, because I was recently at the regular meeting of vice chairs of health boards, which I started to attend, and there was a very interesting briefing by Public Health Wales about the work they're undertaking, which obviously we're plugged into on diabetes strategy. But I was a bit disappointed to see that, according to their figures, we have the lowest level of implementation of what they call the 8 care processes, which are, I think, primary care, basically, and obviously are important in preventing people getting into hospital. I mean, it was not that low. I think it was around 50% that we were doing. People were getting those 8 care processes, but there's obviously scope to do better. So I hope that we keep a focus on that. I'm sure we will, but just to highlight I think the other figure that really struck me, and I, as an ex-researcher, I did query it, was that 10% of secondary care costs relate to diabetes care. And when I asked, was that care related to diabetes or care of patients who had diabetes, it said it was definitely care related to diabetes rather than so presentations to do with diabetes rather than just people who had diabetes were being treated for other things. So and the second point, and it may be this comes up under the finance report, Russ, I was just interested in 256.4. We talked about savings, progress on identifying savings for next year, which of course is approaching very rapidly. So I just wondered whether we could perhaps have a brief update on that. I'm quite happy to do that under the finance report, if that makes sense.
Great, thank you much, and I'll ask Chris to bear that in mind. Rhian, what you got?
Yeah, just support what Gareth said about diabetes. That's very much of considerable interest to QSE committee. But the other one that leapt out at me a little bit was advanced practitioner utilisation will be transferred to QSE. Happy, but that came out of the blue a little bit, and I think it might be quite useful sometime to clarify the scope of that. What practitioners are we actually talking about and where? So I just wanted to note that, yes, fine, but what exactly is it?
Diolch yn fawr, Rhian. A gobeithio gall rhywun baratoi nodyn I ddanfon I ti fel cadeirydd y pwyllgor am hynny. Yeah. Anything else on the action log that you want to highlight, Phil?
Diolch, Chair. Just that we've received an update from the owners of the actions for all of the actions that are on there. Some of them will be closed when the next PFIC committee, the Performance Finance and Information Governance Committee, sits. They're reliant on that, so they're still outstanding, but satisfactory progress. 271.2 related to terms of reference is still outstanding. It's on the agenda under corporate governance, and we'll be able to close it after the meeting at the next floor. Thank you, Chair.
Diolch yn iawn. Rhywun arall? Unrhyw beth ar yr eitem yna, gwelwch yn dda. Os nad oes, yna dyn ni'n hapus I dderbyn yr eitem yna. Diolch yn iawn. Ymlaen felly I eitem 1.5 a stori'r claf, a dwi am droi Nick, dwi'n credu I gyflwyno'r eitem yma. Nick, over to you, please, for us to see this item. Thank you.
Thank you, Chair. And if I may, I suggest we listen to the patient story, which is a very powerful one, as those who've read the paper in advance will already have predicted. And then, if I may, Chair, perhaps summarise some of the key actions we've already taken as a group after we've heard that story.
Diolch yn iawn. A dwi'n meddwl bod yna fideo I ni wylio rwan, bydd y tîm yn trefnu bod y dechnoleg yn gweithio ar y sgrin. A bydd yna gyfle, fel mae'n dweud I ni wrando, o wedyn clywed beth ydy'r gweithredu'n ddilyn hynny. Fel mae'n dweud I ni wrando, o wedyn clywed beth ydy'r gweithredu'n ddilyn hynny. Fel mae'n dweud I ni wrando, o wedyn clywed beth ydy'r gweithredu'n ddilyn hynny.
December of work, and I was doing some paperwork, and when I got up off the desk, my left leg was completely dead. December of so I fell to the ground, and I just was work. I was like, what's not happening, and put myself up and doing some paperwork there. And when I got up off the desk, on both legs, was completely dead. December of so I felt it sort of disappeared again. And I basically work. I said to my mate, it's not coming near that one. And so I gave myself a bus stop because I'm not going to disappear there. And when I got up off the desk from the bus stop, I sat completely dead. December of so I felt it sort of disappeared again. And I basically work. I said to my mate, it's not coming near that one. And so I gave myself a bus stop because I'm not going to disappear there. And when I got up off the desk from the bus stop, I sat completely dead. December of
Ni gwerthfawrogi bod bob amser her I gael peth yma I weithio'n iawn, ond nawn ni roi chydig bach o amser i'r tîm drio cael trefn ar hynny ac yn gwerthfawrogi bob amser yn y cyfamser gai peth yma awgrymu iawn. Nawn ni roi chydig troiad Nick I falle trefn nelliad. But Nick, I wonder, whilst we're grappling with the technology, you can just get a line of what is the case, what was the patient experienced, how did we respond as a health board, and how can we take some assurance that there is progress in this, so that, and then whilst we're doing all that, hopefully our colleagues will be able to see if we can get the technology working, and it is working now, I believe. So whilst we had that, we'll try again. Diolch yn iawn. Cynnig arall, Annie.
December of 2019, I was at work. I was a prison officer, and I was doing some paperwork. And when I got up off the desk, my left leg was completely dead. So I fell to the ground and basically was like, what on earth is happening here to me? I put myself up on the radiator on the desk and sat there, and I had pins and needles on both legs when I sat there. But that was it. It sort of disappeared again. So I said to my mate, I said, can you give me a lift home? And she said, I can give you a lift to the bus stop because I'm not going past your house. I went, yeah, that's fine. So from the bus stop to my house is a 5-minute walk. It took me 3/4 of an hour to walk that walk. And I leaned on railings the whole way down. Where I lived is a lower part, so I had to go down these spiral steps. And as I went down the steps, it was agonising pain. And the next thing I could feel a sensation on my left leg. I couldn't explain it, but when I looked down, I wet myself. Monday I still wasn't feeling great. Phoned the doctor. They said I can give you an appointment tomorrow, and I was like, I'm taking that. And walked up to the doctor, which took me nearly 2 hours, and that was basically again another 15-minute walk. And when I went in, I was so lucky to have a doctor that had worked with spinal care, and she said, have you ever heard of Carter Queen? I was like, no. She says, I think you've got symptoms, I probably have to do a few more tests. So she did all these tests, and next thing she was on the phone to neurology in the Miller. Once I came up here, they did all these tests, sent me for an MRI, and I was blue lighted to the wall. And the next thing I knew, I was getting into theatre and had to have decompression on my spine. My nurse came in and she started explaining what it was, and I was like, and the first thing she said to me was, thing about Carter Queen, and people don't understand, it's a spinal cord injury. And your nerves are damaged. The following year, end of March, start of April, I was in the garden with my granddaughter and my daughter, and I reached over a table like this. And basically I felt an elastic band had pumped up my right leg, and I completely wet myself. And when I went to the hospital, every time I said Carter Queen, they were going, yeah, we have to get your COVID test. So I sat in a wheelchair for 11 hours in A&E. And they were going, the doctor came and they went, we'll get you an MRI. time, and I was like, right, belated to the Walton again. It's like waking up the next morning and I couldn't feel anything in my groin area at all. When I said to the surgeon in the Walton when he phoned me, I said, but you gave me 2 operations. And he went, but you have to realise the operation won't cure you. What they do is just stop it from getting any worse. And I think that was the most real thing I heard from any doctor in my life. And I was just like sitting there going, so there's no cure for this. This is my life now. While I was in the Walton, I was supposed to be going to rehabilitation. So I sat for 16 days in the Walton. And eventually they couldn't get me into rehabilitation anywhere in Wales. And they sent me home. Anything of support, I've actually had to go out and find it myself. Because none was offered apart from rehabilitation. And because Wales wouldn't give it to me, because I got treated in Walton. But then I went to the doctors and I said about, you know, needing a wheelchair, I need this, I need that. And they basically said, oh, you have to come in and see us because we don't know if you need one or not. So eventually, after so many months, I think it was 18 months before they actually gave me a wheelchair. And the wheelchair they give you is not the one you need for the quality cleaning. I found websites and people I could talk to, you know, Facebook things for support as well. Moving forward, they helped me more than anybody else. My daily day is basically pain. Constant pain. Then if it's not bad, is you've got a UTI. It's like today, I've got, you know, my catheter on, but I've also got an nappy on, just in case. I'm 54 now, and I'm thinking, God, I used to think about, you know, people smelling the urine, and now I'm one of those people. When I got out of the hospital, I had people coming round, but I lived in a house at the stage, so I was either living upstairs or I was living downstairs. Until recently, you know, I now live in a disabled bungalow. I lost my job because I was a prison officer, so I can't do that job. So at 50 odd years, you know, you look at yourself and think, what the hell can I do now? But then because you're in so much pain, you don't want to do anything. But then that's where your mental health goes. When you explain to somebody that you're grieving for the health of you, they don't understand what you mean.
Ie, diolch yn fawr iawn am rhannu'r stori yna a cyfle i ni ddysgu gobeithio ag a deall y profiad yna mae'r person arbennig yna wedi mynd trwy fo ac yn byw efo fo. Nick, over to you maybe to give us a summary of how we have responded as a health board to that particular case, maybe.
Thank you, Chair, and I'm glad we could hear that from the patient, because the power of the story and the devastating impact, I don't think I could possibly have conveyed that by trying to summarise the issues. It's a very difficult area, and also it shouldn't rely on a patient feeling lucky that their doctor had experience, that patient's experience was devastating and the impact on her was huge, but it would have been even more devastating had we not recognised it the first time the GP made that contact. So what have we done and what is happening? It's a rare condition. We perhaps see 25 cases each year across our health board. Each GP will have perhaps 2 or 3 patients in their career, but many patients present directly to an emergency department. So each GP will probably have one case that they actually diagnose themselves. So incredibly difficult to ensure that we are assured that the standards are consistent and everybody is in the right place to be able to recognise this as an early stage. But we need to do our very best and to be assured that we are doing what is possible. Thanks in great parts to Angela. Our links now across into Northwest England with the Walton are a lot stronger, both in terms of our communication, our receiving data and feedback, but also, as we heard there, about the discharge into rehabilitation, which is available in North Wales. That was a communication issue, and whilst there are areas in that rehab we would want to improve, it was a tragedy for that patient that there were so many delays in getting that important rehabilitation. So thanks to Angela for leading that. And also Yvonne Rimmer, I think who was brought this story, and one of our spinal physiotherapists who has provided very strong leadership in this area. She now comes to the National Spinal Network, which I happen to chair, and to ensure that Betsy Cadwaladr, although our patients aren't treated in the South Wales neurosurgical networks in Swansea Bay and Cardiff and Vale, that we have clear reporting of access, quality, patient experience across the whole of Wales, because previously much of that has been a little bit difficult for us to see because of the links between North Wales and England. Education, though, is key, and we saw that here. The paper refers to a good educational event that took place in the East, and dates are now in place for the Centre and the West. My worry, though, Chair, is although there were 88 people, I think, at that event in the East, that is but a very small fraction of individuals who might come into contact with these people who are suffering from this terrible condition. So it's how all the alerts in the world, but how can we really bring it to people's forefront when it happens so rarely? And I think then there are some proposals and a demonstration of how we are working across Wales to ensure consistency of access and that our patients aren't disadvantaged in terms of ensuring, for instance, that there's rapid access to spinal physios at time of diagnosis. There's an equitable access to MRIs, which are key, MRI scanners, which are key to early diagnosis. So very happy to take any questions, Chair. A lot of work happening, but still one of those areas that I personally worry about because of the condition's rarity.
Nick, that's very useful for us. Felly, unrhyw gwestiynau, unrhyw sylwadau, anybody wish to add anything? Just trying to see Mike first. Mike, your contribution, please.
Joel, Chair, it's not a question, it's an observation, really. I agree with Nick. I think these stories are very powerful teachers. There's a lot to learn from them. And you've outlined the problem is there are a lot of very rare conditions that our healthcare and medical students won't see during their training, but have to be prepared for when they do happen. And that's actually quite difficult. So one suggestion is perhaps as the board and university are working together on the medical school development and healthcare programs, that perhaps we ask your permission to make this sort of patient story available to our healthcare students, because I think it would. The problem of the learning they would do about this condition is they would not see a patient with it. So it might just drive home that they're ready when they do see these unusual symptoms and they're ready for it. So I think that might be a good collaboration, not just for the medical students, but for the nursing and other healthcare students. So just a suggestion.
And on that, perhaps we can give some thought to not just this story we've had in this board meeting, but all the stories we get. How can we maybe create a library of this and wider patient experience as well, that we can share with others in the health system, as it were? You know, if we can give some thought to that and how we can use it in a really positive way, particularly as Nick has said, and Mike, the cases that are quite rare, when we've got some knowledge about that, I think we have a duty actually to share that. So if I can ask, we give some thought to that and maybe report back on the action on that. That would be really useful. Bertha, Nessa.
Just one comment on sharing. It's always worth going back and checking consent because they may have agreed for this one.
Yes, absolutely.
But my comment really was around, no one would be able to navigate the system until they need to. So that knowledge about who to ring, how to speak, what kind of questions to ask. Obviously, you don't have that, do you?
No.
And just wanted to ask about the information that's given to patients. So obviously we've got Llais here today, but there's also community navigators, in every county. And do we have that information when we meet with patients? Do they get that information about how they can get help with navigation?
And navigating the system is complicated.
Very, very, very complicated.
And those people who are weak and vulnerable, it's extra pressure. Yeah. Dylan, can you beth i'ch ychwanegu ar hwn?
Yeah, I just wanted to make the point really in this day and age, there are electronic solutions, clinical decision support tools which support primary care in particular, with things like, not to say that they would point to any of these rare conditions.
No.
But I'm just making that point again. In the 21st century, electronic healthcare record systems with clinical decision support tools are a support for clinicians to point them in the right direction, not to make the decision. So I just wanted to make that point that we need to be thinking about that.
And something we need to raise awareness of. Yeah. Diolch. Mike, nesa, wedyn Dyfed, wedyn Vaughan.
I think, I'm sure it's been done with thanking that lady for what was a very frank, honest and sometimes distressing account of her experience. I think Dylan maybe has alluded to what I was going to ask, but I was going to ask, when we're inputting data, patients' data, when they present at A&E or whatever, hopefully, data and algorithms, etc., will flag up or red flag some of these rare conditions that, to be fair to the doctors, they've never heard them or never been presented with such a case. Because we can't expect any doctor to know everything about every ailment, so it's I don't know. I'm sure with the development of data and algorithms and what it will actually eventually flag up these conditions. Could I ask just a question? At what stage within the process of somebody presenting an A&E are we likely to pick up some of these more rare conditions, from triage or in my ignorance?
Good question, and we hold that for a minute. We bring others in. Nesa, dwi'n meddwl oedd Dyfed.
Diolch. Mr Cadeirydd, dwi jyst isio pigo fyny ar bwynt nath Bertha neud, ydy'r gefnogaeth i'r bobl yma. Sy'n nid yn unig yn mynd trwy sefyllfa feddygol, ond yn amlwg fel mae'r stori ma'n hyn di dangos yn mynd trwy yn feddyliol ac yn emosiynol hefyd. A dwi'n meddwl mae cefnogi pobl trwy hynna yn rhywbeth. Mae rhaid i ni ddysgu wrth gwrs o achosion fel hyn, ond mae rhaid i ni wneud yn well weithiau hefo y cyfaddau bod angen i ni wneud yn well mewn cefnogi pan mae yna achosion fel hyn yn digwydd.
Dwi'n meddwl bod hwnna'n bwynt pwysig yn dydi, nid dim ond y driniaeth neu'r ymyrraeth uniongyrchol feddygol, ond y gofal yn gyffredinol sydd angen ar gleifion wrth fynd trwy system. Mae'n gallu bod yn eitlef. Dwi'n meddwl bod ni gyd yn nabod bobl, falle aelodau'r teulu sydd wedi cael profiadau tebyg ac pa mor heriol ydy. Vaughan, dros at y ti.
Ie, i mi, y pryder gyda fi wedi mynd ar y cyfryngau cymdeithasol, a di fanna ddim yn lle iach, weithiau fi'n chwilio am gymorth, wyth bo hi di mynd mor frustrated os ydych chi, felly cyfathrebu yn rhywbeth sy'n dod allan yn bob un o hyn, dydy, a mae hwnna'n neud efo newid diwylliant yn y marn i, felly os da ni'n medru newid y diwylliant, bo' chi'n gofalu ac yn meddwl lle mae'r unigolyn yna'n mynd rŵan pan mae'n cyrraedd adra, pwy mae'n cysylltu fo mwyn cael gofal. Fel awdurdod ar lleol, da ni'n gweld yn aml bobl yn cysylltu â ni yn dweud, da ni'n medru cael drwad i bobl wisio cydar yn y siawyr er enghraifft, da ni'n reid o'na, dydan. Dach chi'n bod, mae'r effaith yn fwy, dydy, mae'r garag yn y dŵr mewn ffordd, mae'n mynd allan. Ond poeni fi bod hi wedi mynd ar y cyfryngau cymdeithasol, chwilio am gymorth, pan bobl yn dweud, fel ddim yn lle iach yn aml.
Na, pwynt da iawn, a mae pobl sydd yn mewn sefyllfaoedd anodd tri unrhyw beth. A fel ti'n dweud, y peryg ydy, ti'n mynd i rhywle sydd yn mynd i bod yn o gymorth. A mae'r gair cyfathrebu, nawn ni ddod yn ôl at hynny mewn adroddiad arall berthnasol. Dwi'n siŵr. Cyn dod â Carol i mewn a Nick i ymateb i sylwadau. Rwy'n arall, dwi'n meddwl.
Gareth yma.
Gareth, a wedyn Gareth. Gareth. Na mi droi at Gareth yna gyntaf, wedyn Gareth yma.
Just an observation really, from listening and reading the information we've got in front of us really. And it's I suppose it's a reminder to us as the health board how important our focus on creating and working to these standards, these clinical standards and guidelines is. You know, it's clearly something we have got to focus on, but this sort of example is sort of underlines how important they are in respect of making better and more informed clinical decisions and doing that in a timely way that ensures good access for patients. It's also a way in which we can better understand how well we are performing. So where are we against the standards, and where are we against the evidence base, and how well do we match up with that? And those are key elements, I think, of where we're trying to go in terms of our standardisation, really, of care in North Wales. So they're a vital element, I think, these clinical pathways. The other observation is in this particular example is how this spans both our commissioner and our provider status, and I think that's an important point to note, because there's a very obvious gateway, I guess, between that sort of pathway. We do send a lot of patients over the board into specialist services, and they do come back, and clearly the more we can bring back into North Wales, the better. But there is a gateway there in which care can go awry for a variety of reasons. So again, these clinical pathways really need to drive improvements in those commission and provider pathways. Thank you.
Gareth, good points there.
I was trying to unpack this a bit, because it's a very distressing story, and without in any way wanting to move away from that, I was trying to unpack what are the different elements, and some of them we can't do anything about because it's a very distressing condition, clearly, and we just there, but for the grace of God, we're just so lucky, and the poor lady has got these things, and we can't cure it. But then there are three other things. So one is that it's very rare, and I think, as Nick said, it was lucky in this case, but we do need to investigate always, and I want to come back to this later in the agenda, about making sure that GPs, in particular our general practitioners, have access to tools that can help them. The third area is communications across the board, and communications between health and social care. We can and we should be improving that. But the last bit, which I think is the bit that perhaps I shouldn't say angers, because we have only got patients viewing this, but it comes back to a story we had a little while ago about not being listened to. So it was really the point where she said, well, I went to A&E, and this was a woman had been there and had the operation before, and she said, I kept on saying Cauldron Queener, and they just weren't, no. And that really, if that is right, that is unacceptable. And that comes back to our old questions about culture, doesn't it?
Yes.
And actually being able to, even I know how it must be absolutely terrible in our emergency department some of the time, but even in those situations, people need to listen to the patient.
Good point. Nick, any response, and then I'll get Carol to wind up this.
As I respond to some of the specifics, In terms of the access to information, there is good information available bilingually, available to all healthcare professionals and indeed to the wider care community. The trouble is, of course, helping everybody to remember that it's there and to have the confidence that when they look for it, they can find it, particularly when things are sometimes labelled with names like Cauda-Equina syndrome, which is obviously clear to all of us now, but perhaps wouldn't necessarily spring to mind if you were caring for somebody in the community with those symptoms. I think in terms of that, what stage would you recognise this in an ED and the use of decision making?
Yeah.
I think AI will be very interesting here.
Yeah.
The particular challenge with Cauda-Equina is it's an evolving evolving symptoms. So hour by hour, the symptoms change. So, and we do, of course, put data in and then rely perhaps on the advice that it gives us then, whereas in an hour's time, we wouldn't necessarily always think to actually consider again. But I think AI may be the answer there. And indeed, there is some research going on at the moment to consider that. I think for me, I'm sure Carol wants to touch on this, it's the holistic care, the compassionate care. And it's, for me, it's not just that label that we're doing things holistically and compassionately, but we're actually doing it compassionately and really listening, as Gareth said, always taking time to stand back and to think. And that is something that, you know, is absolutely at the top of our agenda, isn't it, as a health board, to change that culture and that approach for all of our staff, and also to try and work with our community to raise awareness. So many challenges, much happening, but yet I think it will always remain a challenge.
Yeah. Carol.
Yeah, thanks very much. Just pick up from Mike's comment. I think this is one of the most impactful stories that we've had, actually. Lady, much like us, going along her normal business, and suddenly a very life-changing illness comes along. So there's an awful lot in this, as colleagues have covered. The thing that struck me most is this issue about the person, listening to the person. Gareth, your comments are exactly right. People being experts in their own lives and knowing when things weren't right, having knowledge and something to offer in that clinical diagnosis and the care. So thinking much more for us about shared decision making and how people are enabled by healthcare professionals to be part of that. That's, I think, what we're sort of referring to when we talk about culture, but that's culture and system and practice as well. For me, seeing the person beyond the illness, because I heard a lady that was saying my life's been turned upside down. My employment has gone, my ability to do the day-to-day things are gone. What's our role, together with others, in supporting people to cope and manage and thrive as best they can in those life-changing circumstances? So it's beyond the clinical treatment, it's the support of the person. And then on a very practical level, Gareth referred to this, our commissioning and our planning of pathways, because we could have made this much easier for this lady, and we should have, and that's the standard we need to achieve. Now we're going to do a lot of work on commissioning and pathway management, because just because a person from North Wales is being cared for in west of England or wherever doesn't mean we leave them to it. And so our responsibility is much broader there. And then just finally, on the point of using these stories, I think they are so powerful that if possible, with all the right permissions, that we utilise these in many settings. Angela's nodding, so that's good. To make sure that not just the 20 people in the room, but hundreds and thousands outside. So thank you.
Diolch yn iawn. Caroline, diolch yn rhywbeth.
Ie, dwi'n meddwl bod yn bwysig hefyd bod ni yn sicrhau bod lle mae cleifion yn cael ei hanfon i ysbytai tu allan i'r gogledd, Lloegr, wel, Lerpwl arbennig, nifer o ysbytai gwahanol arbenigol iawn yn fanno, 2 ar y ddegau. Mae'n bwysig bod gynnon ni gysylltiadau fel bwrdd hefo'r ysbytai yna, fel bod nhw'n gwybod sut i ddod yn ôl atan ni, fel bod ni'n ymwybodol be fydd anghenion y cleifion yna. Nid yn unig o ran y gwasanaeth iechyd a bwrdd etig y baled, yr o gwasanaethau cymdeithasol yn y cynghora hefyd.
ie.
Felly, oedd o'n ddiddorol dyna gyfeiriad at Walton yn yr
Ie, ie.
enghraifft yna.
Ie.
A dwi'n meddwl fysa fo'n fuddiol i ni jecio ydy'r cysylltiadau yna rhwng gwahanol dima
Ie.
yn ei lle yn ddigon effeithiol.
Diolch yn fawr am y pwynt yna. And thanks for the summary, Carol and Nick. And there's a couple of things I'm sure we may discuss later, but I guess everything that we've heard today and the stories and some of the other things we can consider is to do with an organisation's approach to the service it provides. And one of the things many organisations do is to run the organisation for the organisation's sake. We do that, don't we? Of course we do. But we don't exist for our own sake. We exist for the people we serve. And that's the change we need in Betsy Cadwaladr University Health Board. I think we may talk about that a little bit later, but it's that recognition that we're here to serve people. You know, we're not here to serve the organisation itself. That's really difficult to change, actually. It's the most difficult thing to change, especially in the health board, especially when people are under huge pressure. But the other thing as well that I picked up from this story and others is that everybody in the system should be valued. So it may be in a case that a receptionist may suddenly think, hang on a minute, this patient, there's something not quite right. That person's judgment should be valued. It's not all about a hierarchy. It's not all about because you've got certain letters after your name. It's about the judgment that some people make based on the relationship they've established with someone who's just come through the door and so on. It's really, really important. So I think there's lots we can take out of this, and undoubtedly we'll say some of the things in a report that will come just a minute. But I think it's a huge resource, and so we'll be pleased to know how we can take that forward to spread the learning and some of those messages, so we can really try and grasp this culture change we require. Ag I orffen Rhian, pwynt ola.
Just rhywbeth bychan bach. Somewhere in the papers, and I can't remember where, there was just that, wasn't it? Somebody in the doctor's surgery in Ruthin had identified a birthmark which could have been malignant, and in fact it was. So that's exactly what happened there. It just struck me.
Yeah, no, good point. Diolch yn iawn, a diolch am baratoi adroddiad yna, a diolch i Angela a'r tîm a pawb sydd wedi bod yn glwm wrth hynny. A diolch am ddewis y stori yna. Mae wedi bod yn ddirdynol, a wedi bod yn werthfawr iawn, ac dyn ni eisiau gweld sut mae'r dysgu yna yn datblygu yn sicr gael ni diweddariad gobeithio mewn cyfarfod dilynol. Ymlaen â ni, felly, i 1.6 ac adroddiad newydd, adroddiad profiad dinasyddion. Dwi am droi at Helen i gyflwyno mewn munud, a dwi am wahodd Jeff o llais i ymuno ni hefyd, gan bod Jeff yn mynd i gyfrannu at yr eitem yma yn ogystal. Helen i agor, os gwelwch yn dda. Diolch, Helen.
Diolch, Cadeirydd. This is a new report. Previously, the public will have had an opportunity in this section to ask questions to the board, which is something that happens every single day, of course, and they get answered all the time. This is an opportunity to bring some of the greater themes together that exist in the conversations that we have with patients, families and carers on a day-to-day basis, both inside Betsy Cadwaladr and also through colleagues who listen to those patients on the outside as well. And so what you see in this paper is a combination of insight that we have gathered either through our own PALS team who are in our hospitals and on our sites, listening to people in the moment, conversations that we have had with the public, whether that's through routine engagement that we have. Members of my team are out and about all the time talking with different people, but also in the last 2 months there were a couple of public meetings as well that were attended by colleagues here today, one Batusa College and another that was in Tywyn. So we're gathering information from those as well. Also, we have correspondence from our members of the Senate and also Parliament who routinely write in on behalf of their constituents, and so we gather themes there. And then finally, our colleagues in Llais they have their ear on the ground and are having day-to-day conversations with people about their experiences with Betsy Cadwaladr. So this report brings together a summary of all of that. There's a little bit of detail that's added in order for people to understand some of the negative and some of the positive that we hear. It does not answer the so what in terms of these themes are very important. What are we doing about them? They will be picked up in papers that are in the board pack. And today we can see that the improvements around quality and services and care is an in-depth paper. So that's an area where we can look at in more detail what is happening. We were meant to be joined by Leon, a colleague from Head of Patient Experience this morning, but unfortunately he's not been able to be here due to other circumstances. But we would have had a PALS colleague with us as well as Llais to be able to add more detail or respond to questions. So I'll leave it there, Chair. I'm happy to take any questions, but obviously we have Jeff as well.
Great. Helen and Jen, welcome, and we'd be really interested in your thoughts, not just about what people are telling you, but actually this way of presenting this information and you know our ambition to try and ensure we capture learning and the knowledge in order to improve our services. So be really interested to have your thoughts about that as well.
Thank you, Chair. I was pleased to see this report, and I was pleased to see it was something of a warts and all report. I think it's important that board members see that there are issues, that there are problems. Can't resolve those problems unless you know what they are. And the themes that you hear, we hear all the time. We have we are the statutory provider of advocacy services in relation to health and social care. And we deal with about 500 written complaints a year. And those reflect your concerns. We have a great deal more detail. We use Datix like you do and can produce the same information, which will triangulate what you have to say. We're switching to a new system in a couple of months, which will give us even more detail. Interesting to hear the lady previously saying that she was her own care coordinator. Really, she had to bring it all together. And we hear that a lot now. We particularly hear it from people with severe enduring conditions. One of the issues seems to be post-pandemic, and those links between GPs and secondary care seem to have broken down a bit. So we'll get people telling us that they've been waiting for test results, and they ring up the GP and they'll say, well, receptionist will say, here's the phone number of the consultant secretary, you ring them and check. And I don't think that's acceptable, because some of those results need interpretation. They're not clear. neither is it acceptable just to say, oh, your results were good. They need to talk to somebody, and that used to be the GP. I'm sure it still is in many, many cases, but it seems to be a trend. You have in there delays in surgery, and you won't be surprised to hear that we hear about particularly joint replacement, but also cataracts. You had a really excellent scheme for fast tracking cataracts to a private concern. I think it was on the Wirral. That was very, very well regarded. We recently did a deep dive into what it was like to wait for a long time. We did that a few years ago, and people were saying that they wanted treatment closer to home. What people were saying last year was, we don't care where the treatment is, send us anywhere. The other thing which was slightly worrying in that survey was people didn't see waiting for NHS care to be a realistic option. And we're hearing increasingly about people taking out loans or mortgages, families clubbing together to get private treatment. Generally, those people didn't have private medical insurance, so they were worried that they'd be on their own if it went wrong. Well, they wouldn't be. You would pick it up. And even more worrying, people were talking about going to Turkey and Morocco, and we've all seen what that is. We have been working, I think, more closely with Betsy Cadwallader on various issues. So I think about Tywin, and we need to follow that up, by the way, Chair. And Betsy Cohen, which was very well received. There is another GP practice in the offing, and it's really good to work with our Betsy colleagues on that. And I think the benefits of that, and I think they're in the report here, that some very senior officers turned up at that meeting. They were able to answer questions directly, and these were people who had the ability to answer, to give the definitive answer. So there was no confusion. I think that's a great help to remove that confusion. And I think I'd like to see this report being used in that way to remove confusion on issues. So it's clear to the public what Betsy Cadwallader is about, what they will do about things. And I think that the report and the previous patient experience highlights the need to work in multi-agency ways. I don't think in this day and age it's acceptable to treat people and then discharge them and not worry about what happens later. And I know that colleagues here are really on board with that, and we just have to make it happen, really. I'm pleased to answer any questions about what we've been doing. And we're working with your board secretary to bring to you a more helpful report. We're all in early days. We almost regard Betsy Cadwallader as a new health board now because of the level of change. It's not entirely new to us because we see people we've known for many years come forward, like Gareth. We work closely with Gareth and know his commitment to patient involvement and patient focused services. So I'm very hopeful, and I think this report is. I like the way it's done, and let's see where we go with it after this.
Thank you very much, Jeff. Diolch fawr iawn. Ag just gair gen I yn sydyn cyn ddod i drafodaeth na cwestiynau. Ond na digwydd o uchelgais gan rai ohonyn ni i gael yr eitem yma ar yr agenda. Fel yn bod ni yn cael rhywbeth oedd yn reloio yn agored am brofiadau y pobl dyn ni'n gwasanaethu. Dwi eisiau pwysleisio un peth, dwi'n cael lot o hebiaeth gan wahanol bobl yn stopio fi ar y stryd. Rai pobl yn dod i'w tŷ, ac dwi'n falch iawn o hynny, ac mae profiadau pobl yn amrywiol. Rhai pobl yn dweud bod y gwasanaeth maen nhw wedi derbyn wedi bod yn wych iawn iawn. Oedd Carol fi mewn cyfarfod rhai wythnosau nôl efo rhywun amlwg yma yn y gogledd yn y sector gyhoeddus ac oedd o'n disgrifio'r gwasanaeth oedd yn cael fel Rolls Royce oedd o'n dweud. Felly, dyn ni yn cael ymatebion sydd yn wych iawn iawn. Just cwpl o bethau dwi eisiau pwysleisio o'r themau. Dwi eisiau hefyd pasio'r buck chydig bach a gofyn i Carol a gyfeillion o'r gorau. Be all ni wneud efo hwn i gyd? Sut allan ni gael y gorau allan o'r wybodaeth yma, a dwi'n deall wrth gwrs bod gan yn pwyllgorau ni rôl yn hynny o beth, ond dwi'n meddwl bod yn bwysig bod y bwrdd yn gweld yr eitem yma ac yn tanlinellu bwysigrwydd o. Dau beth i fi, un neges glir sy'n dod allan dro ar ôl tro ydy cyfathrebu. A mae cyfathrebu ni yn amrywiol, y ffordd dyn ni yn cyfathrebu efo pobl. A'r pwynt arall ydy, yn y system, mae y cyffyrddiad cyntaf, cysylltiad cyntaf, mae rhywun yn cael efo'r bwrdd iechyd yn aml y bwysica. Nid oherwydd pan ydych chi'n codi'r ffôn, mae person pen arall y ffôn yn datrys y holl broblemau chi, ond bod nhw'n gallu creu teimlad yn chi bod chi'n teimlo'n hyderus a bod chi'n teimlo bod rhywun yn gwrando fel wedodd rhywun gynnar. Rhywbeth penodol i mi ofyn i rai o'n cyfeillion cydweithwyr ydy rhestru aros a amseroedd aros. Mae yn y newyddion heddiw o ardal arall yng Nghymru fel mae'n digwydd, ond mae rhywbeth dwi yn reit bryderus amdano fo. Be allan ni wneud i gryfhau'r gyfundrefn aros fel bod y profiad yna yn well i'n dinasyddion ni. Ar hyn o bryd, y reality ydy, a falle mod i angen datgan buddiant yn hyn fy hun, ond yn gyntaf, dych chi ddim yn sicr os dych chi ar restr aros pan dych chi'n mynd mewn i system. Dych chi ond yn gwybod bod chi ar restr aros pan dych chi'n cael llythyr am eich apwyntiad. A weithiau, dych chi'n disgyn allan o'r system. Dych chi ddim yn gwybod bod chi yn y pen draw ar restr. Ac yna, os dych chi'n aros am driniaeth eitha arbenigol neu triniaeth ble mae'n lot o alw, dych chi'n mynd i faros yn hir iawn. Oes modd i ni ofalu am bobl sy'n aros tra bod nhw ar y daith yna. Dwi'n meddwl bod hynny'n bwysig. Dwi ddim yn golygu bod ni'n gallu deud wrth bobl dych chi'n mynd i gael eich pwyntiad fori, ond dyn ni'n gallu gofalu am bobl tra y bod nhw'n aros fel petai. Mwyn gwella profiad, mwyn i bobl deimlo mae yna rhywun yn hidio amdanau fel petai. Na i stopio fyna, bydd y gyfle i eraill ôl i cwestiynau, dwi'n siŵr, a wedyn nawn ni ofyn am ymateb. Jeff, I'll just turn to you first, because you've been provoked by some of the things I've said.
No, I think that last chain of thought was really important. We have lots of people coming to us about their waiting times. We can't push them up the waiting list. No. And as we all know, that's done on medical priority. And one of the things we do is explain that the waiting list is dynamic. So it's possible for you to be at the top of the waiting list for a long time because there's always somebody. One of the things that we do with Nick, with Carol, with Angela, is we communicate what has changed about the patient's condition. And there doesn't seem to be, and it comes back to this difficulty in accessing primary care, there doesn't seem to be a mechanism for the patient to communicate how things are changing. So we've done that in the past. and the treating consultant has reviewed that and decided this is much more urgent than I thought.
Yes.
Let's bring them up.
Yeah.
And if there was some mechanism for that, for people's changing and deteriorating condition to be factored in.
Yeah.
It is, Chair, the looking after people on the waiting list.
Yeah. No, good point. Reit, mae'n rhaid pobl eisiau cyfrannu, dwi'n mynd i ddod â ple gyda sy'n mynd i siarad eto, felly ple wedyn mo.
Thank you. I think this new way of talking about issues and patient experience is really helpful because I think we're seeing the themes more easily. So thank you. I think it's been really useful to do it this way. Just sitting here thinking about, the kind of, I've been on the board now in this position since the end of May, and we keep talking about the same themes, don't we? Lack of communication with patients, sometimes staff attitude being a concern. And I think sometimes we focus a lot here on, if I can call it, the kind of medical issues, and it feels to me that what would be most useful for patients, and we've all been here, is a singular point of contact who follows my case through for me, who is that link person. So it's a bit like the community navigators I referred to it before. So if I'm in hospital and I need to come home, who can help me navigate where I need to go? If I'm on a long waiting list for 2 years, I can accept that if I know that I'm on the list and that I'm being regularly reviewed by either my GP or somebody else. And these sorts of roles don't need to be hugely qualified. They're people who can listen, they're people who care about people, and they're people who understand the system and can navigate and be that kind of contact. And I think, we always talk about how starved of resources we are, but I think some investment, more investment in the future, perhaps we'll have to make savings elsewhere, but more people who can be that contact and route through the system, I think, could really help to transform people's experience, because I think most people are prepared to wait if they know what might happen next or when they're likely to get treatment. And what worries me significantly is the numbers of people taking on debt to get treatment privately. But I understand why people are doing that. It shouldn't be the case that people are feeling so concerned about perhaps the limitations on their life while they're waiting for treatment that they will perhaps do something they're going to have to deal with for many, many years to come. So I just think in terms of thinking about where we head in terms of the model that we're going to be working towards in future, we can't underestimate the value of more people in the system who are just appointed to help people find the routes. And I think that could really help to transform patient and public experience. And, the whole thing with the GP, some people like us around this table will advocate for ourselves. Many people are very scared of, speaking up for themselves and whether they've got the right to ask a difficult question of a trained doctor or trained consultant or police person or fire person. So I just think having some more grit in the system that helps people with that would really make a difference.
You've got some very good points there. Vaughan, Nessa, wedyn, Del, dwi'n meddwl, Karen a Gytha.
Diolch. Mae profiad yr unigolion yn bwysig I mi, a sy'n gyda fi diddordeb dath mwy ynglyn â gwaith pawb am bod wedi synnu yr niferoedd mor ystal. Yn 2 fis, felly swn I efo diddordeb yn fath mwy am y gwasanaeth yna. Ond peth arall sydd wedi'n siomi mi digwydd ydy agwedda ac ymddygiad staff ynglyn â unigolion. Felly, sut da ni'n mynd i cael y sicrwydd, ydy hwnna'n rhywun yn ffonio pawb ac yn dweud, mi ddari'r person o siarad yn blin efo fi'n siarad yn front ag ata fi, a dyna fo, ta ydy hwnna'n cael ei ddelio fo'n fewnol, a hefyd y cwestiwn ychwanegol, fy siwr, ydyn ni'n y lle da ni'n poeni gormod am fynd lawr gweithdrefna adnodda dynol hefo unigolion, lle dydyn ni ddim yn gwneud hynny. Ond ytrach na os da ni'n poeni am y colli nhw. So felly, sut mae'r cylch yna'n cael ei gael am bod fel aelod o bwrdd, yn hynod o siomedig bod unigolion yn cael y profiad yna mewn sector goffi. A swn i eisiau sicrwydd yr eithanglu bod yr agwedda yna'n cael ei sortio.
Diolch am yn dod yna, newn ni ofyn i gael ymateb i hynny a beth yw'r gyfundrefn i ddelio efo achosion felly.
Ac y sicrwydd bod yn cael ei ddilyn.
Sicrwydd fod o ddim yn just yn gorwedd ar y siwl rhywle neu beth bynnag a bod yna ddysgu ohono fo. Dyna beth bwysig. A dwi eisiau pwysleisio eto bod profiadau mwyafrif o bobl gyda'n staff yn wych iawn iawn. A bod staff yn mynd yr ail wylltir a tu hwnt i hynny. A dyna ni ddiolchgar iawn. Ond di o ddim fel yna, di o ddim yn brofiad i ni ymbalchio yna fo, ti'n dweud. Reit, nesa, dwi'n meddwl, na i ddod adre yn ôl wedyn, ond Adele, Karen, Bertha, wedyn, Angela, you can come to respond to some of them in a global way, if you like. Thanks, Adele.
Okay, thank you. I think it's really insightful in terms of Jeff's feedback and your personal feedback as well, David. This is something from an operational perspective that's very much on our radar. And as you would expect, it's a national issue. There have been issues nationally and assurances sought from Welsh Government, going back to Vaughan's point, in terms of how we communicate with our patients who are on waiting lists, that it's not a standard, you're waiting for a certain specialty is 4 years, that we're actually communicating with individual patients about their individual needs. For us as a board, our absolute priority in this space is reducing waiting times in the first instance. And then for me, that there's three core components. They are communication with our patients. We've been doing a lot of work with our booking clerks, with our waiting list teams and our operational teams in terms of that communication, the personal communication. I think we need to take that task and finish group a step further. And I think, Jeff, Claes involvement as well as clinical involvement to really understand what the communication issues are. The other thing, we have a national programme and we've really embedded this within Betsy called the 3 Ps programme. They are promote, prevent and prepare. And what that is really focusing on, and I think from feedback from patients, is rather than patients just waiting and very often deteriorating on waiting lists, not hearing from anyone for a period of time, is how we can support them with their own condition and getting them prepared and keeping them well while they're on the waiting list. That really helps, and there's far more qualified people around the table than me as clinicians, but that also supports the ability of the patient when they are listed to have their treatment. And finally, the point that I think it was Jeff who picked up about having, there are mechanisms in place for patients deteriorating and clinicians re-reviewing their priority on the waiting list, but it's another complex system. So how do we provide further clarity to our clinical teams and our patients to manoeuvre that process for deteriorating patients? So for me, I think we need to expand the working group we've set up around comms in this space and bring in more of the patient voice, Chair.
Great, that's really useful, Gal. Thank you very much for that. Karen, Bertha, then Angela, then get Carol too. Within Carol.
Diolch. Just to echo everyone's comments, I think this is a really great paper in terms of illustrating and highlighting the extent of challenges our communities facing, from the story of someone in one of our rural communities having to travel all day to get a COVID vaccination, to some of the more harrowing stories like the ones we've seen on the video before. But it just makes me think that, you know, if we've got services that we can take to the community, why aren't we doing it? We did it in COVID. Our rural communities and our older, vulnerable patients who won't make that journey that this lady was brave enough, or gentleman was brave enough to make. We should be thinking, and we could have some not quick wins per se, but you know, we can improve our services quite quickly there. So it was just an observation, really.
Good point. Leon, Nessa.
Well, thank you. There's just a couple of points really. So I'm really interested to hear that there's this focus on communication while patients are waiting. Because probably an obvious thing to say, but when we're busy every day working full time, time goes really fast, but for people waiting, you know, a day is like a year sometimes if you really need a serious condition. So that's kind of an emotional understanding of what that's like and how that can make somebody a bit cross if they're trying to communicate. So experience with Postural Mobility Service, we were successful in finding a way of that communication to increase and improve, and it saved a lot of pressure on the service. So there is real savings in finding a solution to that. So really pleased to hear about that. I think it's really important that everybody understands patient expertise, but what's crucial around that is, when a clinician or a nurse or a receptionist kind of meets the person looking for services, it can take people a while to come to describing exactly what's going on. So there does need to be that space, which I know is hard when everyone's really, really busy, but that's the only way that their expertise and their experience will really get a chance to be heard. And there's just one question really, just probably for Helen, but just to ask, how do we garner and learn from, and the learning from, I know, for example, cancer services have a forum of citizens using their services, and I'm sure other ones will. So how do we actually garner from, in a way, the more embedded in-depth conversations, forums that they may hold, and how do we bring that into this report as well? Thank you.
Iawn, Dyfed. Diolch. Wedyn Angela Carroll.
Diolch. Cyfathrebu di'r gair dan ni wedi glywed yn ystod y trafodaeth yma. Mae cyfathrebu yn rhywbeth da ni'n gallu newid, mae pobl yn gallu newid yn syth, mae nhw'n gallu cymryd camau I wneud rhywbeth yn well nag oedden nhw'n wneud cynt. Mae'r key findings, yn ei ddarllen hyn yn Saesneg, o'r arolwg gath I wneud, 80.92% of staff always introduce themselves, 83.3% of respondents always felt listened to, 80.8% of respondents felt the staff took the time to understand. Now, falle bod fi'n bod bach yn harsh, ond wrth ddarllen hyn, o'n I isio ychwanegu y gair dim ond, only. A dwi'n gwybod bella bod hynna'n I feddwl mae rhywun yn cael canran o 80, ond beth sy'n bwysig yma yna ydy'r bron I 20% sydd yn teimlo bod hynna ddim wedi digwydd, a dwi'n meddwl dyna beth da ni angen mynd ar ei ôl ydy wneud yn siŵr bod yr 20% yna yn siarad, yn cyfathrebu hefo yr cleifion. Mae'n gallu gwneud gwahaniaeth mawr I driniaeth rhywun bod yn gwybod beth sy'n digwydd a pryd mae bethau'n digwydd.
Diolch iawn, Dyfed. Angela, a wedyn Carol I gloi y drafodaeth. Over to you, Angela, and I know you're going to be whispering almost because you've got a bit of a throat infection. So.
I've lubricated, so you'll be able to hear me. So just a few points to feedback on really from Pals is part of my team. So hopefully I can answer some of the questions that Leon may have wanted to answer. So using feedback, we are providing that feedback and collating it currently. I think it's fair to say up to probably last year, we were using the feedback we were getting, we were responding to it, but we weren't really using it for learning. So we weren't sharing it across the organisation, and we weren't making changes large scale. We were just identifying the area where it was happening. Some of the work we've been doing now is to have a repository that says, oh, this happened in YGC, but it's also happened in YG. Is there something else that we need to do wider? And that's a big piece of work that's feeding through the organisation learning forum, and as part of our learning organisation development will be to utilise all that on an ongoing basis. From the point of view of staff, when there's bad attitudes potentially or behaviours, we do address every single one of those. We refer to the matron in charge. If it's a PALS inquiry, we talk to the matron, identify who's been involved in that interaction to see if we at that point can say, is there an issue? What's happening on the ward? It might be factors that the staffing on the ward is stretched and that person is reacting. It's not an excuse, but maybe we can support it from that point of view. We try to triangulate if it comes in as a formal complaint with student nurse feedback, looking at what is happening on the wards, however many other complaints are happening, whether we need to do a wider piece of organisational development work with George's team to identify what's happening there. I myself this week have been out into one of the hospitals talking to a team who've had some challenges about how we interact with staff and with patients across the organisation. We also take into account if it's an agency staff member and whether that is appropriate for us to be utilising that staff within the organisation, feeding back to the agency expectations of standards, etc. So there's a lot of things, but every single contact we do follow up, and very, very infrequently HR processes have to be involved. It can be very much about reflection and looking at how people are supported to enable them to deliver the best care in the most appropriate way with appropriate language. Cancer services and the groups that we have around, patient feedback, etc. They're used locally within those services, obviously. Again, as part of our organisation learning work, we're trying to triangulate that information, making sure any themes are picked up, any good practice is shared across the organisation. It's early days, but I think we're going in the right direction. And then from a feedback point of view, we are now triangulating. We've got our Civica system, our rollout across the organisation. Chris has been supporting the PALS team around being more dynamic around that and utilising Civica and having a regular report that comes through to enable us to utilise that experience in the best possible way. And I think it's stop.
So yeah, you're very on. Thank you for that. I really appreciate it, and it's good to get that insight that you shared with us. So, Carol, maybe summary with a particular emphasis on where do we go next? I have to admit that this is a bit of a work in progress. This report, it's let's see how it goes. But personally, I think, despite everything that goes on in committees, I think it's important that the board decided on this particular item and the public can also be cited. So a view, how can we take this forward and make a difference?
Diolch, David, and I'm going to sound like I'm booming now after Angela. So, yeah, there's a lot in this, and I think it's great. We've been having an expansive conversation about the issues, but importantly for me, just sitting above the individual issues is how we take the feedback from people, a wide range of stakeholders, into our work in a meaningful way. So I think, and that's the so what, I think that you were asking earlier. So there's a couple of things for me really. And number one is, these are themes, these are very helpful themes that should and will impact on what our priorities are for improvement and for planning. So if we look at, for example, the issue of waiting times, how do we take the route through the experience that we're hearing and directly put that as a core priority in our 3-year plan? And how do we then look at the impact on outcomes and experience as a result of the work that we do? So that individuals and groups are completely influencing that. And we have priorities based on the experience of people in North Wales. So the focus on improvement, the focus on outcomes and experience is really important. And I was just wondering whether looking at those thematic areas, maybe an opportunity to bring back reports and presentations on those key areas to show that, you said we did, ideally, we said we did. So there's a couple of things in relation to that, and particularly planned care seems to have come through, and I know there's a lot of work. A couple of comments. Claire's point about care navigation. I think this is absolutely one for our big thinking strategically, because I think this is one of the biggest challenges for modern healthcare now. I looked at this a few years ago, and I met a lovely gent who was trying to manage his wife's 8 different consultant appointments, and she was unwell, she had mobility issues. How hard it was to get through the system and all of that. So whether that's about lots of subspecialism, but people with multiple conditions earlier in their life lasting longer. So that's got to be one of our big problems we help to solve strategically in the future.
And the significance of it now is compared to, let's say, even 5 years ago, people are waiting longer. So, you know, previously you said, okay, well, that's not a very good experience, but before long, I'm going to get the treatment. Now it's 2, 3, 4 years. So the need is great, isn't it?
And we don't come with one thing. We've often got these multiple things.
Yeah.
So that is definitely in that we've got to try and solve that box. In my 30-odd years, I'm afraid to say in the NHS, culture and attitude has been a recurrent theme coming through. And I'm sure it's the same in other caring areas. And whilst Andrew's absolutely right, deal with the issues, see what the issues are in the clinical area. There's something for me about the wider way in which we treat each other and those standards of behaviour and expectations, and we are doing some of that work on behaviours framework, so we can be very clear what the standards are, and we can hold ourselves and others to account, and we can support. But we know staff are often working under a lot of pressure, so not about blame, about support and encouragement to move forward. And then I think just in closing, the potential for much more flexible models of care. I think it's Karen's point, but Jeff had talked about ophthalmology. We're going to come on to ophthalmology in the performance report. That is one of our biggies now. How do we provide more flexible care, often in different places? So not a traditional, that's a hospital thing, that's a home thing, that's a community thing. But again, you know, we've got some good examples, but we need to make sure we don't retrench to the tradition, because the pandemic did dislodge, did make us think differently, and we need that sort of thinking into the future clinical strategy as we go forward. Yeah.
Diolch yn iawn, Carol, am hynny, ac mae'n grynodeb da. Dwi eisiau bod yn glir yn dwi'n sbio'r Diane fan hyn a Bill, ond yn y pwynt gweithredu o'r dyfodaeth yma, dwi'n meddwl dwi eisiau bod yn glir beth yw'r pwyntiau yna, pwy sy'n gyfrifol am wneud a be sy'n digwydd nesaf yn y gyfle i adolygu hynny, dwi'n siŵr. A'n uchelgais ni ydy'r un bwrdd iechyd bod ni gyd, bod yn staff i gyd, a'n pobl dyn ni'n gwasanaethu cael profiad gorau posib lle bynnag maen nhw yn y bwrdd iechyd, lle maen nhw'n byw yn y gogledd. A dyn ni yn, we come back to those words that we've used a lot over the last months, Carol, is standards and quality. I think it's the two top words, I think, in our discussions, and it is to do with the equality around that and the ambition. And somehow we've got to instill that in all of us. So first of all, we must have it to begin with. You know, everything starts with us, not with somebody next door. Everything starts with us. Our standards, our ambition, our quality will set the tone for the rest of the organisation. Never, ever forget that. I'm speaking to myself as much as anyone else. Seriously, you know, let's not ever forget that that's part of our leadership role. So instilling that across the organisation so that whoever access whatever services will have that best possible experience. Doesn't mean it's going to be perfect, but the way people are dealt with, the way people are treated makes a difference. Those, what sometimes we think in the great scheme of things are small things, makes a huge difference. So I think we can take a lot from this item. Let's have a think how we can develop it. Jeff, you and your colleagues can have a think, okay, how maybe you can participate in this and how we can develop it and where we go with all the learning. Let's not lose it. Let's not lose it. Let's use it. And we want to see action from it. That's the key thing. I want, looking at various chairs of committees, have a think as well what committees can do with this. If it sits rightly in some agendas, I know. Diolch yn fawr iawn i bawb am y drafodaeth. Dan ni wedi cymryd dipyn o amser dros hynny, ond mae wedi bod yn werthfawr gobeithio. A diolch i Helen a'r tîm am baratoi y droddiad da iawn. Diolch yn fawr iawn, Helen, os bosib diolch i bawb. At yr eitem nesaf, y droddiad y cadeirydd, dwi ddim am dreulio gormod o amser ar eitem yma gan bod yn rhedeg yn hwyr, ond fel arfer tanlinellu un y ddau o bethau falle sydd yn ddefnyddiol i bawb wybod. Un ydy, dwi wedi darganfod fod y Nadolig yn y bwrdd iechyd yn gyfnod lle mae lot o bethau'n digwydd, a lot o bethau da'n digwydd, a lot o bethau lle mae corau o gleifion yn cynnal gwasanaethau, a mae companiaid eraill yn neud lot o waith werthfawr, a mae wedi bod yn bleser gen i cael y cyfle i muno yn rhai o'r gweithgaredda yna, fel dwi'n gwybod mae eraill wedi wneud, a dwi'n credu bod hynny'n yn cael i werthfawrogi gan ein staff ni. Felly diolch i bawb sydd wedi bod yn cynnal o wahanol weithgareddau yna. Dyn ni hefyd yn ymwybodol bod y cyfnod y geia, dyn ni dal yn y cyfnod yna, wrth gwrs wedi cyfleu pwysau ychwanegol. Dyn ni hefyd wedi cael gweithredu diwydiannol, ac yng nghanol hwnna i gyd, mae'n staff ni wedi gwneud ymdrechion clodwiw i gael bylches sydd wedi bod i gwneud shiftiau ychwanegol, i wneud diwrnodau ychwanegol, i newid i patrwm shiftiau, ac mae'n rhywbeth dylen ni fel bwrdd yr un neges glir allan bod ni'n ddiolchgar iawn am yr ymdrechion o gwmpas hynny yn benodol, a diolch eto i'n holl staff. Un ymweliad jyst i ddweud gair byr, fe nath y Prif Weinidog Mark Draper bod drefn ymweld a ysbyty Wrecsam Neilor yn bennaf i gael trafodaeth gyda Gareth a fi'n Carol, ac mae'r Prif Weinidog presennol yn rhoi gorydd i, wrth gwrs, cyn bo hir, ond oeddwn ni'n falch iawn bod o wedi creu amser i ddod ato ni i gael y drafodaeth, ond oedd o hefyd wedi cael cyfle i drafod efo pobl yn yr uned yn hedfan ar safle ysbyty Wrecsam Neilor, ac dwi'n meddwl bod o wedi cael argraff da iawn o'r gwasanaeth yna, a staff wedi bod yn falch o'i ymweliad o hefyd. Felly, eto, mae'r ymweliadau yma yn, dwi'n meddwl yn gwneud gwahaniaeth o ran cyfathrebu, o ran bod y staff yn gweld bod ni'n rhoi dipyn o sylw i sicrhau yn bod ni'n gallu siarad efo pobl ac ymweld â wahanol safleoedd. A'r Prif Weinidog i hun yn gwneud hynny, felly dyn ni ddiolchgar iawn. Na i stopio fyna, a dwi'n hapus wrth gwrs i ateb unrhyw gwestiynau yn ôl yn arfer. Diolch yn iawn. Unrhyw un eisiau holi unrhyw beth neu gwneud unrhyw sylw? Os nad oes, diolch yn iawn. Ymlaen i'r eitem nesaf, adroddiad y Prif Weithredwr, neu Prif Weithredydd, beth bynnag, dach chi am ddefnyddio. Carol, over to you for your report. Diolch yn iawn.
Diolch. Thanks very much. I'm in the spirit of just catching up a little bit. I will be very brief with the report. It's a shorter report than usual. We did have Christmas and I had a week off. So my usual site visits were a bit lower this time. But as the chair has just said, there's been a lot going on. the seasonal celebrations were fantastic. It was my first Christmas here in North Wales. Thoroughly enjoyed it and saw the real spirit of community across the health board. So that was lovely. And I was actually on one of the visits that I have done. The chair had been there a week or so ahead of me and previewed it to say you're going to love this, and I did. The minor academic medical and surgical research area, and it would be great to have some more information come through on this. And really quite groundbreaking research going on, particularly around prostate cancer. So whilst we talk a lot about all of the challenges, rightly so, we have got some real gems of work going on as well. So I did say I would take the opportunity to flag that so that they knew that we value their work very highly. It has been a very difficult time in terms of the seasonal resilience, winter resilience, and adding on then industrial action, not just in Wales, but in England, and our border relationship across to particularly the counties of Chester has meant that we had a couple of weeks of real challenge. As you say, Chair, a lot of people that have undertaken a lot of work. It would be very hard to name everyone in there, but people will know who they are at gold level, silver level, out in the services and on the front line. And you know, we managed. It was disruptive, but we've managed that situation. I'd like to personally just draw attention to the health and safety executive. It is in my report there, but to publicly again apologise to the family of a lady whose care that we failed in, to be quite straightforward about it. Was a very difficult hearing, and one that brought home to me certainly the impact of when we don't get things right. I think we take a lot of learning from that incident, and I commend staff for the efforts they have put in to embed that learning, and we're determined to make sure that learning continues to be driven forward in a positive way. I'm sure we're going to come on to planning at some point, but we are earnestly in planning now for the next 3 years, having had the Welsh Government planning guidance and the budget. So I know that we will touch on that. It's going to be a challenging but potentially exciting opportunity. Not potentially, it's going to be challenging and exciting. Not potentially, opportunities ahead. We've got a lot to do, but we've got a lot of good things that we can help make happen. And then what penultimately, working with partners, a note there, but I did want to flag that yesterday we re-signed the Armed Forces Covenant as an organisation. We are one of a few organisations across Wales who have reached the gold level of accreditation, which is fantastic in our work with veterans, and via the Ministry of Defence, that relationship is reaffirmed. Nick, with his own past background in the armed forces, leads this. We were both there to sign it, and we're delighted to do so on behalf of the board. And then finally, Chair, after I said I'd be brief, I'm not. But I do want to say this. You will notice that Teresa Owen is not around our board table. Thank you, Jane, for stepping in to cover. But she is here, and Teresa has stepped down from the role of Executive Director of Public Health. She is not leaving the Health Board, however. We made sure of that, and I want to thank Teresa. Been here 9 months, but known Teresa longer in the NHS Wales for her extremely diligent and very highly valued contribution to public health and the wider agenda here in North Wales. And I'm delighted that Teresa will be working with us on mental health improvements, one of the top priorities of the Health Board. So very pleased with that. And then Adele, this will be your last meeting. You're on holiday at the end of the month. Thank you for stepping forward on the secondment and your contribution. And then the final part is that we have successfully appointed a director of corporate governance. That's the start now of our drawing substantive executive team together. So I'll end on that.
Carol, and can I also say to Adele, many thanks for your work over the past months. And I know that the commute sometimes is quite challenging. Those of us who use transport for Wales on the basis can have some thoughts on that as well. But we're really grateful for all your efforts and the work you've done, and we wish you well in the future. Thank you for coming today and contributing. Teresa, mae'n deud rhywbeth bod rhywun sydd yn newydd adael swydd ddim yn gallu aros I ffwrdd ac yn gorfod eistedd mewn trwy. Mae hynny'n deud popeth am Teresa, dwi'n meddwl. Dwi'n falch iawn bod ti yma I wrando ar eiriau Carol ac ni'n fel bwrdd yn gwerthfawrogi ar holl waith ac dyn ni'n edrych ymlaen at barhau gweithio mewn cyswllt arall i'r dyfodol. Felly diolch I Teresa a diolch I Adele unwaith eto. Unrhyw gwestiwn, unrhyw sylw? Gareth gynta.
Just a very brief question, Carol. So obviously the annual plan is critical, and I'm glad to hear, and I know from elsewhere that I think progress is being made. I just wondered what the arrangements for the board, informally as well as formally, to have an input, because I know we'll get to sign it off in March, but I'm very anxious that all the members of the board get the chance to look at it.
Yeah. Please don't be anxious. Literally yesterday, we had an informal executive session where we were laying out the steps. And we recognise that there's a couple of steps we want to confirm with particularly independent members of the board to make that contribution. Recognising that our board development session in February is already chock-a-block, we might need to be quite flexible in how to engage. But we will have an outline. So rather than start with a blank piece of paper, have an outline in the next 2 weeks or so, I think. So certainly, by early February, which might give us some substance on which to have some further discussion. So, Chair, if that's all right, I know we're leaning on independent board members' time a lot at the moment, but to be able to put into the diary some flexible opportunities to have the discussion, that would be great.
Diolch yn fawr, as usual. Rhywun arall gwestiwn ar y adroddiad? Carol?
Swn i'n just cael bach ar y cyfle fel aelod cystwllt sydd yma yn rhan y cyfarwyddwyr gwasanaethau cymdeithasol hefyd. Diolch I Teresa sydd wedi bod yr unig berson cyson yn siŵr sydd wedi bod hefo ni fel awdurdodau lleol, a dwi'n gwybod da ni gyd wedi gwerthfawrogi yn edrych ymlaen gweithio hefo Teresa. Dwi'n gwybod pa weli eisiau e-bost yn dweud bod hi'n mynd, a wedyn do fi ddim yn mynd, oedden ni'n reid falch bod hi ddim yn mynd. Ond da ni'n edrych ymlaen I gael ymlaen efo Teresa, da ni'n diolchgar iawn I fi am bod mor gyson ac yn barod I drafod pethau ella sydd tu allan I maes I weithio pan dwi'n neb addas I drafod hefo, felly diolch Teresa ar rhan o'r dod o'r lleol.
Diolch yn fawr, gwerthfawrogi sylw yna. Reit, diolch yn iawn Carol am y adroddiad. Ymlaen i'r eitem nesaf, sef eitem 1.9, adroddiad yr is-gadeirydd, a cyn I Gareth ei gair ddiolch I Gareth am ddod ag adroddiad i'r bwrdd. Mae'n datblygiad newydd sy'n cael ei groesawu ac yn gyfle I bawb weld y gwaith mae Gareth yn gwneud. Yn ei swydd ers, dwi'n meddwl, mis Tachwedd, dwi'n credu, ac yn gweithio'n galed iawn ac yn derbyn lot o wahaniadau I ymweld ac yn cadeirio lot o gweithgarau gwahanol ac yn ddiolchgar iawn iddo fo am ei waith. Adroddiad Gareth dros at y tîm.
You're very kind as normal. I don't want to speak really to this report. I'm sure people have a chance to read it. Just two things. Firstly, to say I'm sticking my head above the parapet and giving you my thoughts as they evolve. I know people who know more about the subjects than I do may differ, and please put me right now or outside the meeting. But I didn't want to just sort of give an account of what I was doing, but also what I was thinking. And the second point, at the risk of embarrassing her further, is just I want to say how tremendously helpful Teresa's been in the first bit has been getting my head around the mental health, adult mental health. I've obviously got a lot more work to do, but she's really helped on that front, and I'm very glad she's staying in touch and in office dealing with some of those issues. So I'm very happy to answer questions, or obviously to talk outside the meeting about my emerging thoughts. Thank you.
Diolch yn fawr. Gareth, Vaughan?
Ie, dwi'n mynd i ddechrau ar y cyfle, o Gareth di cynnig hynny di gwir. Mae yna un sylw'n cael ei reid fan hyn ynglyn â y ffaith bod awdurdod lleol wedi tynnu allan mewn ffordd o gyd-drefna lle da ni'n wedi cael yn coloceitio.
Ie.
Lle da ni angen edrych a trafod hwnna mewn unolder. Dydy hwnna'n cweit yn egluro'r sefyllfa.
Ie.
Lle fel bwrdd, mae'r bwrdd angen ar dall pam mae hynny'n digwydd.
Ie.
Ie. A dwi'n meddwl bod o'n stori
Ie.
lle da ni angen bod mae'n fwy cyfartal yn y trafodaeth.
Ie, ie. Ac dwi'n gwybod fydd Gareth yn mynd yn hynny.
Yeah, I mean, since I wrote the report, I mean, I think you're absolutely right, Mon. Since I wrote the report, we did have the first meeting, and with me involved of the Together for Mental Health, and I've agreed with Alwyn from Wrexham, who has been very involved in that work, that we're going to work up a bit of a paper to discuss this within that context of partnership. But obviously, I think you're right, that needs to come to the board. And I certainly don't in any sense want to estimate the pressure that's on the local authority colleagues as well, but I think we need to sort of understand what the pressures are and see if we can make sure that we not necessarily just go back to what we did before. That's often not the solution, but make sure that we've got those connections right. So thank you very much.
Iawn, unrhyw un arall? Dylan, dwi'n credu? Na, just yn codi llaw. Sorry. Na, pawb yn hapus. Iawn, diolch o galon I Gareth am yr adroddiad ac am bod yn barod I asgell amrywio mae'n gwneud ac mae'n cael ei werthfawrogi yn fawr iawn gymuned fel bod a dwi'n gwybod gan staff felly. Diolch o galon I Gareth. Dyn ni'n mynd I cymryd toriad rwan, sydd hynny yn iawn. Pawb yn barod am doriad falle o 10 munud, na I ofyn i'r criw technegol stopio'r darlledu am y cyfnod yna, cyfle i cael toriad hefyd. Mae'n 18 munud wedi 11, nawn ni yn ôl i'r stafell am 28 munud wedi 11. Ysgolch yn dda, mwyn dechrau hanner. Felly 10 munud, ysgolch yn dda, diolch yn iawn. Diolch yn iawn bawb a chroeso yn ôl i cyfarfod bwrdd ni yma yn Llandudno heddiw a dyn ni'n parhau gyda'n agenda ar eitem 2.1 ar diweddariad ar y mesurau arbennig, eitem sefydlog wrth gwrs ac eitem bwysig i ni a dwi'n droi at Chris Sbogna i gyflwyno eitem yma. Chris, diolch.
Yeah, thank you, Chair. You'll see the report in front of you is slightly briefer than the previous reports that we've brought. I'd just like to assure everybody that's not due to a lack of effort. It's just simply the timing of the board meeting and the information that we've got prepared to bring. Cycle 3 is well underway. In fact, we're midway now through cycle 3, and the exec team met yesterday to review progress on that. What I would say is the milestones for cycle 3 are loaded quite a lot towards the end of cycle 3, and that's really because of the Christmas period. And because of that, I haven't included an update against those milestones here today. It wouldn't have added a great deal of additional information, but there are some examples of progress within the narrative text within the paper. At the last board, I estimated that when we got to the close of cycle 2, because we weren't there at that point, we'd probably be in the order of 2/3 of the milestones having been completed within cycle, and that is exactly where we fell by the end of the cycle. What I would say about that, because there is a risk that we'll focus upon the third that we didn't achieve, we were very clear and have been very clear that the approach for special measures should be realistic, but also should be ambitious. And so, you know, within the complexities of a health organisation, all the codependencies and the unpredictability, I think 2/3 is roughly in the right place. 100%, and we wouldn't have been ambitious enough. Even 80%, recognising the complexities of the services we deliver, we probably wouldn't have been ambitious enough. We have a formal closure report for cycle 2, which I will circulate in the coming week once that's just been finalised. There is reference then further in the report to the independent review process that colleagues will be familiar with. I can say today that we now have all of the reports for accuracy checking, so we'll be able to bring those through, timetable those through now once those accuracy checks have been done and we've received final versions. The last point I think before I finish is you'll see at the end the change log. I have approved the contents of the change log for working purposes, but colleagues will be aware that it then comes through to board for ratification.
Great, diolch yn iawn. Chris, Carol, did you want to come in at this point, or do you want to listen to contributions from others and then? That's great. Very much. Claire, we'll come to you first then, please.
Diolch. Thanks for the report, Chris. So one strategic point and one more operational type of question. So I like the fact that we are taking the themes from the independent reviews, that what we have got now is a set of themes to work on. So a kind of straightforward question around that in terms of the 3-year plan that we haven't yet seen. I'm hoping and expecting that they're going to be so for that. Yes, so thank you. Carol and Chris are both nodding at that, so thanks very much. The second question, which is more detail, is we're speaking here about good progress around oncology, and yet when I look at the risk report, the next item, there is no updates on progress around cancer pathways. Sorry, so we say oncology, we're doing well. Maybe we can get that step down a bit in terms of intervention levels. But then in the risk report, it hasn't been updated and it's still scoring 20. So my question is, are we as an organisation making the connections and the links between the special measures action plan, our risk management framework and our performance framework? Because we need to, they all need to tell the same story. And I can accept that there may well be some slightly different actions in special measures improvement plan to what we have in the risk management framework, to what we have in the KPIs. But even so, at the board level, we need to join those things together. So when we're saying we're confident that things can be stepped down, we've joined all the dots.
And that does raise the question of different things in different reports. So which one is the truth,
yeah,
if you like, you know, that which report reflects the situation as is, recognising that reports at different times and
yeah, and I'm sure there isn't any untruths anywhere,
No.
but it's
Absolutely not.
but it's where the judgments are being derived from for different aspects of things we're working on, isn't it? And then what that means for the overall position on something. Yeah.
We'll let Chris come back, but when we've had other comments as well, Chris, you can think about that one. Thank you. Rhywun arall isio codi mater? Chris, do you want to just respond to that, and then we'll get Carol to make some general comments as well.
Yeah, thank you. So it is exactly as you say, Claire, in that the focus within this has been in terms of the factors that caused oncology to be identified as a fragile service for special measures. In retrospect, the language in the report could be slightly clearer in so much as we are recognising the improvements from special measures, and that has then prompted us to start thinking about how do you de-escalate a fragile service, rather than necessarily saying we are at the point where we believe that service should be de-escalated, because all of that triangulation does need to occur.
Carol?
Yeah, great. Thanks. Thanks very much for the opportunity just to contribute on this item. Couple of thoughts, and then I'll try and incorporate Claire's in at the same time. So what I was going to say was this is the last public board meeting before the milestone of the 1 year special measures. So clearly our thoughts are turning to that and stepping back a little bit to think about, okay, the 9 months, which would be 3 90-day cycles. Where did we start? What actions have we taken? What impact have we had? And what assurances have we had? In terms of where we are on the journey of improvement through the first period, into, and it's exactly to Claire's point, to why we were nodding so vigorously, all of that channeling through into the 3-year plan. So the themes are very important in all of the reviews, but so are then the individual recommendations and making sure that they're in there. So all of that moves across. And then the big item, as you've quite rightly said, Claire, is the connecting pieces and the alignment. So we just started some discussion about how we present all of that. So, for example, on templated number 1, what were the issues that took this particular matter into special measures? What action have we taken? What impact has that action had? And where are our assurances of that impact? Be that all Wales or Healthcare Inspectorate Wales or other sources of assurance that we can draw in. So we're going to be working very much on that to get us ready for the year ahead. We are also working on the issue of corporate risk register and BAF, and where they sit to help us understand where our risks to delivery are on the BAF side and where the risks are organisationally. So just to finish up, we continue to have the Ministers' Improvement Forum for all of the board. We've got one of those coming up, and we continue at the executive level to have the Special Measures Assurance Board with the Director General and the NHS Wales Chief Exec, and that is also coming up. So we've got those different interactions as well to contribute.
Great, thank you very much, Carol. Rhian, wyt gen ti hefyd?
Yeah, just, I know we're on a journey and, you know, 3 cycles will have passed. I remember sometime, I'm not sure, it might have been in a minister's meeting or with Welsh Government, that we were going to be given an indication about what needs to be ticked off in order to be considered for de-escalation somewhere down the line. And, you know, particularly since we've got a different level of escalation as zapped into our landscape over the last couple of days. So I just wondered where we are on that.
Yeah.
I mean, I know we're not going to say by 12 months' time, will it be different? I think we'll be different as an organisation, but whether that will be sufficient, I don't know. But I just wondered, you know, looking ahead, particularly when you're in the context of a 3-year planning, where do we see it fitting together?
So I think that's a good question, and there have been some discussions. I think there's 2 or 3 things I think we can take advantage of the 12 months is to sit back to begin with and think, okay, what's been achieved, and an honest assessment of that, and what difference has it made to people's experience of using health and wellbeing services. I think that's to tie it in with that is important. Then secondly, that discussion with government regarding criteria for de-escalation, and then thirdly, okay, what's the next 12 months going to look like? What's the approach going to be? And the learning from the last 9 months, what are we taking from that to go into the next 12 months? I think there's 3 things there that we can almost say, okay, look, 12 months, right, let's take a stock and consider these things maybe.
Yeah, and if I may respond, and Chris, please do add in, but on the first item, the taking stock, I think is really important because we put the 3 90-day cycles in to create the energy drive, the momentum for improvement, but it's not sustainable in that way. And thanks to Chris's function for being able to respond and everyone else on that. So taking stock, and we have that comprehensive view coming back through. The second point, I'm always a bit cautious about using the words de-escalation because that's not the aim. The aim is to build a better organisation and to improve outcomes. But it is important that everyone can see at what level of improvement do you need to achieve in order to start giving confidence we're moving in the right direction. And I think that's still a bit of an outstanding piece, if I'm honest with you, Rhian. Now, I know the Welsh Government officials, because we met with them, are working on this. They also need to take into account the wider elements because, you know, it may be so easy for them to hold Betsy to a higher standard than others. So we talk about standards a lot, so we want to hold ourselves to that high standard, but they've got to also work out where that is relative. And as you referred to, there is a revised escalation and intervention framework being published with another level. It'd be interesting to see how that comes in. And there have been other organisations in Wales escalating. There's not much sign of de-escalating going on. I would say so. You know, again, you know, let's improve. Let's see the impact. Let's see the outcomes, and then into next year, very determined that we have a joined up approach. And what we've learned, I think, from special measures is the way in which we've managed the actions, the evidence, the tracking will be something we need to take through into the wider planning. We've learned a lot. We learned some things about don't overpromise and underdeliver, because some things take longer than others if you're going to truly engage people in something, rather than rush to feel that we've ticked that off, but then it's not embedding. If I may just ask questions.
Yeah, broadly that. I mean, if you think about taking stock, you could take stock in terms of where have we come as an organisation and in the changes in the services that we deliver. There's also something though about taking stock of what have we learnt in doing that and going through that process, and how does that then inform everything else that we do. And in that regard, certainly my team have continued to spend a lot of time thinking and reflecting upon what could we do differently if we continued along this journey, and what lessons are there elsewhere, and in terms of how we report through, in terms of the standards to which we assure ourselves before then sharing data. That all feeds through into lots of other things that we do in the organisation, whether it be learning from incidents through to how we manage big projects. So we have captured that. We've shared it with colleagues in Welsh Government, who I have to say actually have been really good at coming alongside us and helping us to deal with some of those areas of learning, and have then gone on to share that with other organisations who, as Carol says, are now experiencing heightened escalation too. Very happy to share them through workshop as well, around this table.
Diolch yn fawr iawn. Felly, ydyn ni yn hapus I dderbyn yr adroddiad yna ac I gymeradwyo yr eitemau yna, rheoli newid ar addasiadau, a pawb yn hapus i dderbyn yr adroddiad. Diolch yn fawr iawn. A gyda hynny, awn I mlaen i'r eitem nesaf, eitem 2.2, adroddiad llywodraethu corfforaethol, a troi at Phil, ag Phil, if there's anything in the report we wish to highlight in particular.
Thank you, Madam Chair. Yes, I will be as succinct as I can. There's 3 elements to the report. There's the corporate governance arrangements, which I just want to kind of pull some key points to Chair if I can. We've touched briefly on corporate risk register and board assurance framework. I'm going to give a quick update on that, and very briefly just seek endorsement ratification on the Chair's action since the last meeting. So the corporate governance arrangements, since at the last meeting of the board, you were provided with an update on corporate governance arrangements to support the committee and advisory groups of the board. So just a quick reminder, we've now established, due to the successful appointment of independent members, 8 board committees and 3 advisory groups, some of which are new and had an inaugural meeting. So since the last board meeting, there have been meetings with the chair and exec leads of each of the committees to develop a draft terms of reference for the which are received here for the board to approve. I think to use Carol's words, it's been challenging and exciting in terms of time scale for the chairs and exec leads in terms of getting this prepared. So they're here before you for your approval. So I want to, that's the main item really in this section. I want to seek your approval on. And then there's for noting an initial cycle of business for the year 2024-25 for the board to note, not to approve. So I'll stop.
Right. Diolch yn iawn. Pawb yn hapus I dderbyn hynny? Gareth?
Just very briefly, I mean, I think there is a huge amount of work's gone into this, and I think the substance seems fine. I think Rhian and I have both had the same reflection that there's probably a little bit of tidying up that can be done, and I think between us we're quite happy, Phil, if you don't take it the wrong way, but just to help you sort of make sure that all the bullet points we've got the right sort of start. So they're really the nickety points, but after all, these are very formal documents, and it's very.
Definitely, no, that's a good idea. If anybody has anything else to add, just email Phil, please do that.
Thank you very much. Thank you very much, everybody. Thank you, that's great. So I'm asking you to note the cycle of the business as well. So just key thing to pull out, Chair, I think, is that we've had inaugural meetings for what's now called the People and Culture Committee,
Planning, Population Health and Partnerships Committee and the Mental Health Legislation Committee. And all of those have resulted in an inaugural meeting taking place since the last board meeting, which is really encouraging. Now got our governance up and running, which is a really good link to Chris's special measures paper. This is a special measures objective, so it is key. I just want you to note that cycles of business, will change. They are slightly a live document, if you like. They are going to be amended. Those 3 new committees, or re-established committees in particular, are committed to having a committee development session where further work will be reviewed around the cycle of business and work programme of that committee. I just wanted to note that. Okay. Thank you. I'm going to do the introduction to the corporate risk register and board assurance framework together. So I won't go into this in the detail I was going to, because I think we've had an introduction to it in the last item, really, and I know that Carol might be keen to come in with some thoughts that we've discussed in the executive team around how we manage risks more effectively. But the reports in appendix, it's appendix 3 on page 66 is where the detail is. But in the paper itself is a summary of the key corporate risks and the key board assurance framework risks. I think the reflection on writing the report and discussing it with independent member colleagues since I've written the report is that the board assurance framework in particular will benefit from a focus on having clearer strategic objectives, which I know that we are very keen and committed to doing as part of the planning process. So I would like to identify that, we do have to produce a board assurance framework. It's a requirement to do so. And our audit colleagues will soon tell us if we were doing it. So it is important that it's here today, but we do have to append it to our strategic priorities that are in the annual plan. So I will leave it at that, if I may, and then any questions.
Did you want to say something about the other item on Chair's Act?
Oh, that's sorry, Chair. Yeah, I will very briefly if I can. So since the last board meeting, there's been 2 Chair's actions that have been taken. One was in relation to Welsh Government funded discretionary capital allocations, and that was taken on the 28th of December. The second was related to the approval of pay agreements during industrial action in line with NHS Wales guidance received by all health boards and health organisations. Both of those Chair's actions were well engaged with by independent members and officers alike, exec team members alike. Very detailed, comprehensive notes have been made and recorded. They're here really for the board to, got a full view of it and can be ratified.
Great. Diolch yn fawr, Bill. And just on Chair's actions, with noting that's those are Chair's actions that have been taken for the first time, and the reasoning is because of the timescales before it wasn't possible to bring anything before the board. But we took a bit of a hybrid approach. You can take a Chair's action where the Chair can consult with a number of IMs and ask people to sign it off, but we did hold a meeting where everybody was available and then took the Chair's action. So it was quite a broad approach despite not bringing it to the board. But so that's important that we know that, I think. So diolch yn fawr iawn, Phil, am yr adroddiad ar y gwaith. A'i gwestiwn I, Claire yn gynta, a wedyn dwi yn wedyn Gareth.
John, I still think we're really confused about the difference between board assurance framework and register, because there are still elements that are repeated in both. And I think the development of our medium-term plan and our core priorities is then going to help us to do a whole refresh of what's included in the BAP and what's in the corporate risk register. And I think, the climate that all public sector organisations are working in is high risk at the moment, and therefore the whole principle around risk management is that these are really useful tools for officers and for board to understand what the key risks are and what we're doing to manage and mitigate them. And yet when I read this, it feels like it's a process, not that it's a useful document for the organisation in managing and mitigating risk wherever we can. So it feels like it's a document that people have to fill in when it's the board. And actually, when you look at it, it hasn't been updated by some service leads and areas. And I think we've got timescales for when the risk at the current rate is going to be able to be mitigated down that are quite unrealistic, with some really long-term things around population health and things where we've got a date of March 24. So I think I know how much time we as a board and the office team have spent on this, but I think we've still got a fair way to go. So I have got a number of individual points, but I won't make them. I'll kind of stick at the kind of higher level for here. And I just think we have to get to a place where people really value this, use it on a day-to-day basis. When something changes in their area, they're updating the document. It isn't just a document that you pull together for the board. So I hope that.
Great, I know Carol will have something to say about that in a minute, and I'll bring Gareth in, but just to add to it, and then I'll bring you in at the end, Carol, is I wonder if we got this in the right sequence where we're getting reports saying, okay, these are risk, there's mitigation, but do we as a board then need committees to look at that in detail and give us the assurance that it's actually working?
Yes.
So it seems to be information for us.
Yeah.
But it's not assurance. So
yeah, I think
we should turn it the other way. I think it feels a bit like that.
Also, I think there's two levels, because I think actually we shouldn't be at the board, particularly on the BAF. I think the recommendations is to note it. I think we ought to be confirming whether or not we are assured that we've identified the right risks and that we're managing them effectively.
Yeah. Okay, so give some thought to that, please. So Rhian, Gareth, and then Carol, or if you've got anything to say also.
Mine is just a general plea, you know, sticking my head above the parapet. I don't understand a lot of this. And I'm going to say the same with Russ's finance stuff. I don't understand it. And if I'm trying to be seeing it from the point of view of our population, a member of the public, does a member of the public understand the risk scoring mechanism? You know, or is it just to think of a number? We all talk about, we know what a risk of 20 is. Well, do we really? But does the person in the street know what that is? I mean, the heat maps look lovely. They're very pretty, but I'm not getting anything out of it that means anything to a person who I might be sitting next to in a doctor's surgery. So I think it's just, I'm losing, getting lost in the detail. And I'm just wondering how it can be more meaningful and useful and supremely relevant in the way that Claire is describing, really. It's not a process with little tick boxes, and putting something like population health and health inequalities on a heat map, it doesn't tell me what that actually means in relation to real action and impacts on real people. So I think it's just a general plea to make it more accessible to everybody.
Okay, thank you very much. Bring Gareth in, then I'll ask Carol and Phil to respond.
Yeah, I mean, I want to say that, you know, I think there is a huge amount of work gone into this, and I think we're sort of getting there, but I absolutely get what Rhian says. And I think perhaps on that we could do with help from Audit Wales and internal audit, just to sort of help us make sure that what we are doing, and I think it probably is, but recognises good practice from elsewhere. So yeah, well, that's a nice one for you. So on my main point, I think you stole my thunder, David, which is basically to say that I think it's difficult to wrestle with this at the board level, the whole lot. So I do think the committees need to do some of the heavy lifting, and then it's for the committees really to say in their report to the board, you know, and by the way, on risk, please look at this rather than having perhaps a portmanteau version in it. And I will, at the risk of trying people's patience, but there are a couple of specifics I would like to raise, because I think that perhaps they also illustrate it. So in the BAF SP16, which is the one about governance, do we really think the risk of not having sufficient governance is still a 4? Because actually we're in the process of recruiting the final batch of IMs. We know that the timescales are now in place for those interviews. I mean, that may not be in public knowledge, but they are happening fairly shortly. So, you know, that seemed to me we might want to question that and possibly de-escalate it slightly, because it is focused pretty much on the, you know, having the bodies and the appropriate bodies. And then on the, I mean, this is really putting my head above the parapet talking about that. On CRR 2405, which is the one basically about overspends, we're saying it's 5, which is almost certain. Does that still fit in with the finance view, which things are improving and we're still working towards? Admittedly, the goalposts have changed, but we were still at the last time. Our formal position vis-a-vis the Welsh Government is that we will achieve the 33 million, which is now what we set as a budget. So I just wondered about the consistency of that. And the final thing, which is a very small point, but I will make because I think it's important, is on the risk appetite, where I think we did a lot of really good work, which I wasn't particularly involved with because I coincided with some leave, which I think is really good, because I think we do need to recognise that we can't be risk averse about everything. But there's just the description of people, which is how we'll be perceived by the public and our partners, I think is probably just a typo. I think it's just taken over from the previous one. So if we could just correct that. So,
Thank you.
yeah, okay. Thank you.
Okay, great. And those 2 examples that you highlighted maybe serve as to remind us that it's very much a live document, isn't it? And it needs to reflect changes in situations and progress and so on, so that that document reflects what we have been told in other reports too. But Phil, if you've got any comments before I bring Carol in. Thank you.
Thank you. Very quickly, just in response to Gareth's point about the board assurance framework risk around governance, just on the overall assessment on page 22, we do kind of assess that if the above deliverables are put in place, then a score of 12 could be achieved by March. It's just buried away, and it should have just needs to shout out a bit more, Gareth. But we had that discussion, I think I'd like to say, in the audit committee when I presented this in November, that we do feel there's a degree of confidence perhaps in proposing a reduction in score on that one. In terms of just very quickly on Rhiann's point, I completely agree with your feedback, Rhiann and Claire. I feel it, and I get the feedback from the team and from independent members. I don't disagree with anything you said, and I know Carol want to talk about some next steps there. But there is some immediate things that I'm leading on, which I think will be helpful, but they're not the total answer. As part of the risk management framework, there's 4 levels of training that we've developed and got ready for a February launch. And one of those, the 4th level, the highest level, is for training and development for board members. So, you know, we are going to put that in place. We did a quick pilot with one of the independent members. I won't embarrass the person. Last Friday, I think they found it useful, and they've given us some feedback, which I think will be helpful for us in terms of delivering it to the rest of the board. We have now identified an oversight, if I use that word, board committee and exec lead for each of the BAF risks and corporate risk registers. So your proposals around the committees, we're ready to do that, and we've started to do that, but much more to be done. And I'll leave it to that.
Diolch yn fawr, Carol, to sort of summarise and how we go forward with this. Sorry, Caroline first.
Just before that. You know, I'm still relatively new to the board, and I think this sound framework that is still evolving. I certainly agree with the points that Claire made about the difference between the risk elements and the business board assurance framework. The one thing I would like to see in the cover reports moving forward is a summary of movements. So are there some new risks that we need to be aware of that weren't previously in the risk register? Are there some risks that are now mitigated to the extent that we don't need to be monitoring them so closely anymore? And what is the movement? Are some escalating? Are some that are there that are getting worse? But also good news, where some things are improving as well. So that's the sort of summary I would like to see in the cover paper. That is, it's a long document, and I haven't got a problem with that. It's for me to go into it to look for the detail I need. But some sort of a summary, a short summary in the covering reports, I would find helpful.
Thank you. Great. Diolch yn fawr iawn. Carol, to sum up, please.
Great. It's really good as the accountable officer to hear people talking about risk. Look, let's be frank about this. We are at the foothills of the development here. And you're absolutely right. A lot of work going on. We approved the framework in September. We are only 4 months beyond that. So there is a lot to do. It's not just the framework at the board, but all the sort of things that sit under the bonnet. So a couple of specific comments in relation to that. So when I arrived here, it felt like the organisation, when it was thinking about risk, was in the risk identification space, not in the risk management space per se. So we've got that move to make there. I think we need to be very clear. I'll come back to Bath, but very clear that the audit committee has a role in policy, system and process. So we need to assure Karen and her committee of that. And then the individual board committees having oversight of the specific risks. Just on ownership for a moment, this item is under the Director of Corporate Governance, but this is for every single executive director to be able to speak to their risks because they're responsible for managing. And that's when I think we're getting a bit more mature, is when everyone is in that space to enable that maturity to happen. Phil and I have been discussing, we had a great discussion, I think it was last week's execs around this, how we're going to put some particular sprint sessions in to help us get ready for that step change improvement. I completely agree about a lot of detail. Now, I'm used to having a dashboard at a glance so that you can see on a side, what's going up, what's going down, and exactly as Caroline says, cover a report. But actually, us having the discussion about whether we think that's right as a board. And we have very, my experience previously, very rich discussions about that. Have we done enough to mitigate this action? What more could we do? What if we put more money in? What if we didn't? And all of those sorts of things. So I think there's that to do. And then the Bath, I think that we've been trying to see the Bath, perhaps corporate risk register and Bath, whereas the board assurance framework should be much more aligned to our 3-year plan. And that is it's a bit like a delivery confidence assessment. Can we deliver the strategic objectives we've set, and what will get in the way of us achieving that? And that's the sort of conversation we're now having. So quite a lot of work to do to try and get us ready for the new financial year. Karen and I hoping to catch up on some of this. I know audit committees clearly working very hard on this. I don't know if Karen would want to comment, Chair, actually.
If I may.
Do you want to comment?
Gave you away. You give me away. I mean, it's just to sort of just put a little bit of context, really, because obviously there's been 4 of us who've been here since February, and to look at this February almost, and to see the journey that we've made and the progress that has made, we shouldn't belittle that by, by not having that corporate history. So for me, we're making great strides, but we are still very immature. But we are a lot further on than we have been. So it's just to recognise the efforts that have been made by the team. It's still another hurdle to jump over, but we are moving in the right direction at least. I think just for everyone to recognise that.
Yeah,
absolutely. Great.
Yeah, good point.
Can I just come back? Sorry, I know I spoke once, but it's a thought that's been triggered by that discussion. And we had a discussion yesterday, David, about how can we make the performance discussion, we're coming on to that, more real, where we actually not just note the issues, but we actually get into discussing, well, what are we going to do about it then? Yeah. And I think what we suggested then, and perhaps we could, I don't know, I know that it's complicated, James, we could align these two things, because what we talked about was perhaps we should have a focus. We obviously need to receive the whole of the performance report, but at each board meeting we have a focus on a particular issue, whether it's urgent and emergency care, or whether it's planned care, or whether it's mental health, primary care. But we could have in a cycle of business the focus on this, and we could then bring together both the performance and the risk. And then as to managing the rest of the risks, we look to the committee reports to bring forward specific things outside that cycle that they want us as a board to consider. So can we just think about that just as a way of doing business? I mean, by all means, shoot me down now if people don't agree with that, or come back to Phil, because but I think that would be a good way of, because otherwise we will just not discuss the fundamentals. We just sort of, oh, yes, okay, noted it.
Well, I think it's an excellent idea, because we did take advantage of a train journey yesterday, didn't we, to have some thoughts about that. But I think the suggestion is then that will bring the whole agenda of risk alive to us, and that's the problem with it. Is it you know, there's a tremendous amount of detail, some great work being done, but what does it mean at the end of the day? It'll only mean anything if you tie it into what is happening at service level. So that was the thinking.
And after all, we don't necessarily need to structure all our reports around who is the lead executive for what thing, because taking Carol's point, we are collectively responsible, and each executive director has responsibility for bits within each performance and
okay, so anything to add, Carol, and then there's something to leave there for the team and maybe exec team to think about it going forward. How can we present things in a way that will be more meaningful?
Yeah, well, thanks again for the contributions. And Karen, you're absolutely right. We're moving along. And although we're impatient, we are actually moving forward. We're not going backwards on this. So I think there's a bit of an acceleration now, because we've got the start of the new year coming, where we'll make a bit more of a step change on this. Certainly, we've got to make those joins and connections. So Gareth, performance is a core part. Wider assurances are another part that we can draw in. So we'll take that away and give that some thought, if that's okay, Chair.
Great, diolch yn iawn. Pawb yn hapus i dderbyn y droddiad, a diolch yn gwaith, pawb yn hapus gyda'r argymellion yna, sgwch yn dda. Dan, diolch yn iawn, felly ymlaen yn i'r eitem nesaf 2.3. And Nick, this is one of your regular reports, I think, about the updated register of approved clinicians. So over to you, please.
Thank you, Chair. And it is indeed a regular report that comes to every board. Happy to take any questions, but the report is there to note the contents and to look for formal ratifications of the approvals that I've made since the last board, in line with the 2018 directions under subsidiary to the 1983 Mental Health Act, which is a function we carry out for Welsh Health boards and organisations.
Great. Diolch yn iawn. Unrhyw gwestiwn rhyw sylw? Nagos. Pawb yn hapus felly i dderbyn y adroddiad ar argymellion, sgwch yn dda. Pawb yn hapus? Diolch yn iawn. Diolch am y adroddiad yna. Ymlaen yn i'r eitem nesa. Eitem 3 a 3.1 yn gynta and to for the month 9 finance capital and savings report. Diolch yn fawr.
Diolch, yes, so thank you, members. I take on note the report is fairly detailed and gives some clear summary messages, but what I'll do is, if I may, just take members through the highlights for each of those sections. So the first one is just to note on the revenue outturn. So we signed off a 134 million deficit plan at commencement of the financial year. We have received £101 million from the Welsh Government through the revised settlement process, which moves our position to a £33 million planned deficit. So that is what we signed up to at the start of the year. We continue to forecast to deliver that £33 million deficit position to close of the financial year. And we have, in doing so, mitigated some significant cost pressures that have materialised during the financial year to get there. What I will say is the Welsh Government have issued us a control target of 20 million. We are not attaining that £20 million control target. We do have non-recurrent income, significant sums of non-recurrent income, that are based upon making progress towards that control target. And we are in negotiation with Welsh Government just to confirm that a £33 million deficit and what we've said we would do at the start of the year effectively is making sufficient progress towards that control target so that we can then secure that resource into the new financial year. And indeed, some of those allocations non-recurrently have been made available to us into the new year as part of the allocation settlement. But we haven't secured them recurrently yet, just because that wording is a little bit loose for us. Helpfully, actually, because if it was definitive, then we wouldn't be able to have those conversations. In terms of how we've got there, and really looking at December's performance, so you'll see the trajectories in the report. We started off with a £5 million run rate risk. As we've gone through the year, that has deteriorated and closed. December is the first month that we have actually received more income than we've actually had expenditure. The £6 million surplus in month is a little bit flattering because we have had some one-off balance sheet movements, provisions released effectively in month. So about £5 million of that performance is due to fortuitous gain. But that still means there's a circa £1.5 to £2 million worth of underspend in month of December. So that's a really positive aspect to the report. And again, as I said earlier, this is the first time we've actually started to erode the accumulated deficit for the year, which was at last time's meeting 25 million and is now 19 million. So that moves us closer to where we need to be at the close of the financial year. It gives us some assurance, of course, that those measures are working.
Yeah.
A key part of that is the savings delivery. So I know we talked a fair bit about this through committees as we've gone through the year. We have now gone beyond the initial plan target of 25.2 million in savings. That's now 25.6. So we have achieved our savings threshold target for the year, which again is a real positive movement from where we were at commencement. And that has clearly helped us in terms of delivering our financial position. And what I will say is in the detail report, you'll see some variance movement. There is a significant positive variance. That's where some of those allocations, i.e. the £7 million from elective recovery, and also the fortuitous gains that we get through balance sheet release, which includes energy provisions and also any provisions we've made for further charges that don't materialise, they all get reversed into that position. So that will include, say, for example, in month, that £5 million movement. So that hopefully gives some assurance around that modelling. In terms of the risks, obviously, we still carry risks going into the close of the financial year. So we've already mentioned quite a lot about the unplanned care pressures and emergency pressures that we are experiencing. And also, of course, we've had a strike, which has driven costs into the position. So we need to just be mindful of those risks as we move forward with the close. I was going to say 3 months to go, but 3 months to go from a financial perspective, 10 weeks to go from a reality perspective, I guess. So those are the risks and the inbuilt risks as we move forward. If I can just touch on capital, if I may, Chair, just to emphasise, we touched on the Chair's action. We did receive 3 significant allocations, circa £500,000 for emergency care, 1.2 million for additional digital investment, and 2.4 million circa for diagnostic equipment, essential replacements. So we have secured a fairly chunky additional resource, and those resources are now in the position. We're targeting about 25.7 million, which I've rounded it differently, so it sounds different to the savings delivery, but it's 25.7 million targeted position. We are about £50,000 over committed, but we believe we'll manage that through the year end. So there's a low risk to delivery now within the capital programme, although it is a low value for the size of the estate that we're trying to service. And then just finally, if I may, just on cash, just to say we did request £50 million worth of support. That underwrote our deficit position plus our balance sheet mitigations that we're putting forward. And there is about circa £14 million of those. So that won't be cash backed. And there is some risk still built into the system. We've remained our position requesting the £50 million. Welsh Government have confirmed to us verbally that they only have the 20 million. They can only cover what is effectively the control target that's issued to the Health Board. We are still in conversations, and they are to formally write to us to articulate what that position will end up being. but there is that's the whole of Welsh Government finances, and I don't believe there are sufficient resources. So what we are doing in the background is working up how we would manage through working capital that level of cash distress, which sounds substantial, but actually £20 million on a £2.3 billion organisation, circa £200 million a month we spend. So we should be able to manage that through our working balances, but it may impact on our public sector payment practice results. So it's just to be mindful of all of those, please, Chair, and happy to take any questions.
Great. Well, many thanks, Russ, and thanks to the team. Tremendous amount of work over the last few months with this important agenda, and we're really grateful everybody for all their efforts. It makes a difference, huge difference, undoubtedly. Right, intro question. Rhian Gynta.
Yeah, thank you, Russ. I think your explanation helped me because, again, there's a lot of it I don't understand. I've never really grasped what a run rate is, for example, and how run rate expenditure reductions are not budget adjusting. Well, it sounds like a different language to me. But that's my bad, obviously, but I think it was very helpful the way you explained. I suppose bottom line, the question really for me is, are we likely to meet the target, which means that the non-recurrent funding becomes recurrent? I mean, that's the big question, isn't it? You know, how likely, what are the odds on that if you were a betting person?
Hold that for a minute. Well, he's not a betting, but he's not allowed to be with the budget.
The answer to the shortfall is 20 million on that. A double or quits.
Hold that. Well, I'm asking this for some questions as well, Russ, and that you can come back to some of the Claire.
It's good to see that we are making positive progress, and it feels that we're making progress because we've got much tighter control around spend in the organisation, which we actually needed to have to head towards these year-end targets with a degree of confidence. So I guess I've got a question about how prepared are we for some of the transformation change we need to make around what we spend our money on, because actually it does feel this year it's been about controlling spend on the current things rather than transformation, and that's where we need to get to around improving health of the population and working to the budgets that we have set for us. It's great to see that things like agency spend are coming down. That's really positive, really positive. Much better patient experience, and we've got a greater degree of our own workforce. So some really good things to see. I guess two things, and I don't know the answer to these, but two of the big areas of overspend is CHC and drugs. How much control do we have over CHC? I don't know. That's why I'd like to understand that better. And in terms of drugs, is it about what people get prescribed, and is there a lot of flexibility to treat my ailments with something cheaper and get the best outcomes? And what are we doing around that, if that's the case? Because they are some really big areas to spend, in addition to the IHCs, of course, being the areas where we've got some of the biggest challenges around spending in our budgets.
Okay, thanks. I'll bring others in.
Plus, might not be able to answer about CHC and drugs, but I'm sure other people.
No, there's a bit of debate going on about that amongst some of us, so that's going to be an interesting question for Carol to come back on, maybe. Gareth and then Karen.
So a couple of things. I mean, first of all, I think there is real progress here, and I don't want to. It's not. I mean, I don't want to undermine Russ, but it's not just Russ. You know, people under me are really working hard on this, and I think there is as positive news. And I particularly, like you, noted the agency costs and thought, yes, that's really, along with reducing the temporary staffing costs, the interims. Those are small things, but they're really important things. I just I'm going to. Where whatever things where angels, fools rush in, and sort of talk to Rhian's point. I think there are two parts. This one is a sort of financial one, one's a political one. So the financial reality is, I mean, and Russ will contradict me if I'm wrong, I think we're still think it's realistic to get to the 33 million. It looks a lot, doesn't it? We're still like 11 million over that. So we've made, i.e. the remaining 3 months, we've got to keep in budget, and we've also got to erode that 11 million. But you do have to think that that's 11 million, and in 3 months we spend £500 million. So, you know, it doesn't seem, when you look at it in that context, it doesn't sound like an impossible task. Then we've got things like the, you know, industrial action and so forth, so that throws stuff out. But I think, and Russell will tell me if I'm wrong, I think there's a degree of quiet confidence we can get to the 33, but whether we get below that, and certainly we probably can't get to the 20 million. And then the political question hits in is, you know, how much the Welsh government really think that all the health boards are going to achieve their stretch targets. And I think that probably they're not. So I think if we can get even a little bit under the 33, I suspect we will look in quite a good position. But I would like, and I bear in mind this is a public meeting, so maybe Russ can't say too much, but it would be interesting to know what he picks up about the other health boards, because my impression is that, as I said, probably nobody's going to get to their stretch target, and quite a few of them I think are going to struggle to get to their original budgeted target. So, you know, I think not over optimistic, but I think there's a quiet optimism that if we can get down to that 33 million or just below it, we may be look in a reasonably good position. I did want to ask just a couple of particular points. There's this wonderful thing that's other budgets in the which has got a massive surplus of where we say we're 18 million under budget. So I mean, I don't know. I don't share a briefing. I'm not really sure what that hides. So it'd be interesting to know that, because, you know, are those good savings or are they bad savings? So basically they're underspending on things we ought to be spending on, although it's fortuitous that we're not, if you see what I mean. And I do want to pick up the point that Claire made about, and it was what I raised in the minutes, about how I know, you know, it must feel like a mountain trying to climb this year, but I know you are doing work, Russell, and your colleagues, and with colleagues across the organisation, about efficiency savings next year, and picking up that point about how comfortable are you that we're on track there, and indeed perhaps improving our performance in terms of those being more about transformation rather than, you know, sort of pressing down on budgets, just good tight budget management. So just one last thing I will say, because it's just we don't talk enough about primary care, and I'm really interested in what we can do about managed practices, because there are issues there about, one of the reasons they are overspending, my understanding is that they're very, you know, quite reliant still on agencies, and there's something I mean, I know it's very complicated, I know that much, but there's something sort of going wrong, because we know there are lots of fairly newly qualified GPs who don't want to manage their own practice. They don't want GMS contracts. Yeah. So what are we doing wrong? Bearing in mind that often why we've got managed practices because the practices have failed in some way. Yeah. But I think it's a real opportunity there, not necessarily to make savings, but certainly to work within budgets, but to use those budgets more cleverly. Yeah. And I'm only at the very, very start of thinking about that, but I do think we've got to work quite hard on that. Okay.
Diolch yn fawr, Gareth. Iawn. Karen.
Diolch. Just a couple of things from me. Just to note that the audit committee received assurance around the improvement in the financial control and compliance with regulations, particularly in relation to single tender waivers and those ad hoc expenditure items, which have decreased dramatically since the team have got a real good grip on that. So there is progress in the right direction there with the team. And then the other one is just more an observation and on what Russ said a few moments ago around we might have a cash issue and we might fall foul of our public sector payment policy. And it's a plea to ask staff to look at, if we do end up in that situation, to be mindful of those that can afford to be paid late and those that can't. So third sector partners, local businesses who are providing services for us who need that cash flow. We need to make sure that, you know, we don't detriment them as opposed to a local authority body that possibly has got a good cash reserve. So it's just to be mindful of that if we are making judgments around who can go beyond 30 days.
Karen. Mike.
Yorkshire. I suppose all of us have got an anxiety, the current sort of adverse position. We've got 3 months to get that right. So I don't think anyone's expecting to pull rabbits out of your hat, but say that we get close to month 12 and we're not there. Do we have any measures that can be added in? I'm mindful, I was an NHS budget holder some time ago, and I vividly remember this time of year being encouraged to spend what was left in the pot. Because it's actually harder to spend a budget than argue for it sometimes, having gained that. So people, laptops would be ordered in the last month and that sort of thing. It's the same in universities, just to reassure you. Do we have any way of, is that a last resort spending control, clawing back unspent monies in individual budgets? I agree with Rhiannon, I don't understand this very well. And that's probably a naive suggestion, but do you have a sort of plan B when we hit month 11, 12 for extra tightening, please?
Okay. Diolch yn fawr, Mike. A Dylan, ti nesa wedyn you'll need to grynhoi. Diolch.
Yeah, diolch. It was just to make the point, building on Claire's point, really. One of the challenges for us as execs that we need to come back on the 3 items we just had, is how we combine those things. So I'm very conscious of the fact that what we have had to do this year, in some cases, is take quite draconian measures at times around the budget without necessarily thinking about the impact onto next year and the year after and our strategic direction. So I think we do need to think about how we join up the BAF, finance and planning and look at them in the whole. So just to make that really, I think that's a challenge that we as execs need to take on.
Yeah. Very good point. And just to add to some of the comments that have been made, if you can maybe share with us this work that has gone on. I mean, some of it has been quite radical, should we say, or draconian, depending on your interpretation. It's because of the financial situation of the public sector. I wonder if you could share with us any learning that we've had in the way that has acted out amongst our staff, and their response to it, and perhaps ways that have gone really well and some ways where it hasn't gone so well, and how we can improve things. That would be really helpful, given that the picture for finances over the next, I don't know how many years, is going to be similar. So it's important that we take any learning and adjust accordingly. So lots of comments, lots of questions. I'm going to ask you to sort out between both of you, how are you going to respond to that then?
Let's take some of the more technical and I'll take some of the more organisational. Does that sound okay, Russ? I don't know. But,
scribbled notes down.
We'll sort it out.
Great.
So I think, I agree with Gareth's analogy in terms of Rhiannon's question. So I think he set the scene. The reality is, though, we're not looking to take that money out. In a sense, we're looking to just keep ourselves. So we'll put the £14 million balance sheet effectively against our current normalised deficit. So we have to find £5 million for the rest of the year and just make sure our expenditure and our income remain aligned for those 3 months to get to the close of the financial year, the £33 million as a deficit plan. So that's what we effectively need to do to get there. And it's within our grasp to do so, and we've demonstrated that through December's position. However, January may be a tough month. I think Claire's point, as well as Gareth's earlier question around what have we got for recurrent savings going into the new financial year, sort of align. And the reality is we've got these cost control mechanisms in place. And I think that we, as a board, we'll need to be assured that we do a transformational piece of work that delivers us savings and gives us assurance around delivery of those savings. And there'll be a key conversation for us around when we release that control mechanism as to when we get assured over those levels. We are developing a programme for transformational savings. It will link in with the value and sustainability work that Welsh Government are doing. Ironically, that covers workforce, clinical variation, non-paid medicines, and continuing healthcare. Two of the latter, of course, are the ones that you just highlighted, and they are significant pressures for us. I would say we have 3 main cost drivers. That is the level of emergency care that's driving our numbers of beds that are open, and we need to understand where we can improve on flow and therefore reduce those costs. These two other work streams, there's quite a national focus on, and all health boards are struggling. So continuing healthcare, there's a real pressure out there for the actual providers, and so health boards are being forced along that line because they are a resource we have to use, unfortunately, to move patients through on flow. So we are working, but what we are doing is assessing the care packages that are discharged with. So individuals who are discharged with a care package. That might not necessarily be what they need once they're out in the community and feel a bit less disorientated. And so understanding whether that cost is true or not and what care packages are out there for those individuals is a piece of work that's ongoing. Medicines management, we're quite advanced in terms of Lois is really leading that and driving that forward for us. We've really moved, and we are nationally reported on a significant move for biosimilar use. Biosimilar are effectively the drugs that have come out of patents, so they're a lot cheaper, but do the same thing. So we've made a dramatic shift to those, but there's more work to do, mainly around prescribing, but also limiting choice around secondary drugs. And that work is ongoing as part of those work streams. But we need to develop those work streams and get that reporting mechanism that will give us the transformational savings. And that will give us as a board a level of assurance that we can then stop these cost control measures going forwards, just to see how we can get sustainable actually in a really coherent way. And of course, it's really important to emphasise the value and sustainability is not about delivery of financial benefit. The financial benefit is the byproducts. We are enabling patients to be discharged instead of keeping them in hospitals, which is not good for them. So we're doing the right thing for the patients, which then has a byproduct of a financial efficiency. So making sure all of that is correct is really important for us, and there's a lot of work to do around that to give the board assurance as we sign the plan off going into the new year. I would say the 18 million, we will give PFIG an analysis of that, so you can dive into it. But it is essentially the balance sheet, the one-offs, the energy provision. They're all recycling back into that pot. So it's not really trading performance, so we've kept that separate. But and then there's underspends really through corporate areas actually, which traditionally do underspend, so it's not unusual for that to happen. But we'll share that detail through. The cash management, absolutely, Karen, really important actually. So when we take the strategy together, I think we will share that through members so that people are clear, and it will be a targeted strategy looking at individual organisations that we are indebted to make sure that we can carry that cash over and not disadvantage our local population and local suppliers. Unfortunately, or fortunately, whichever way you look at it, I've been in this place before, so I've had to do that piece of work before. We're hopeful that we can sort of meet halfway with Welsh Government. So they haven't formally written to us yet saying the 20 million is all we can underwrite. We are asking them to do so, but we are building that supplier list in the background, and we'll absolutely share that with members just to make sure that's really targeted at the right areas. And then finally, really from me, just in terms of the learning, I think it's really important that people understand that there isn't any other money coming through, and there's a real benefit for the health board in terms of securing that non-recurrent resource into a recurrent baseline. And demonstrating the level of investment that has happened over the past 3 years within the health board, and that key reason as to why we want to make these changes in the short term. I think we'll engage the workforce. What I will say is that going through the organisation, because of the layers within the organisation, that message has taken time to effectively get through to the front line as well. And of course, it's the front line who write the checks. So possibly having that greater engagement at an earlier point is really a necessity, and making sure that everyone is very clear and supportive of the messages to why we're doing this and understanding of why we're doing it. I think that's the real lesson. It just took quite a long time to percolate through the organisation, that's all. And we did have some really good wider senior leadership and also wider organisational development sessions where we did get some really good feedback from some clinicians around, we get it, We understand why we're doing it.
Yeah.
And that's a massive difference. If we can get that engagement earlier, I think that's really important for us.
Great, that's really helpful. Carol, over to
Yeah,
you to
just-
summarise.
Yeah, just briefly, I want to deal with this issue of not understanding the reports. We don't expect board members to be accountants, apart from a couple. We do actually expect you to be accountants. But if there is something about translating this into non-accountant speak. So if I just summarise the non-accountant speak just for a moment, so because members of the public be interested in this, because this is affecting how we provide public services. So at the start of the year, we opened a £134 million deficit plan. Not good.
Not good.
Savings were very low, and so the aim was to increase the savings, which has been done, which is very good. Same as every other health board, really off track, and probably not that unsurprising, given the wider issues in the economy. So we had £101 million given to us conditionally. So it's not ours in the bag that we can always rely on. That took us to obviously 101 minus 134 minus 101. God, I feel like they're looking at me like they to get to 33, to get to 33. If we deliver 33, that's what we set out to deliver in the beginning of the year. But I'm going to just say we didn't have a great plan to get to that. So what we've been able to do in the year, and this is in year, it's like putting a handbrake on the car or cancelling the credit card. So we have to stop spending money that was an in-year benefit. That is not long-term. No. That is not the way we want to do things in the medium term or the long term. But it has helped us to do a couple of things. One is it's clearly helped because month 9 has come down, and I can't stress how important a month that is for us. We can do this as an organisation, but it's been quite hard. I'll come back to learning. But it does mean that we have got a problem because the Welsh Government said you need to land at 20 million. And we're likely to land at 33. So we have got to manage some of that. We're not the only health board. There's another 2 health boards, I think, at this stage. Things change. So we've got to push on that. In terms of next year, so Claire's question about how ready for transformational change are we? And I want to just link back to the couple of the items we've discussed about risk. We'll come on to performance, on patient experience, citizen experience. We're not yet match fit for the challenges that we've got. And that's the thing, we've got to get match fit on that. We'll discuss later how we get more match fit and move forward. And Russ has talked about the value and sustainability work. Thanks to Karen to recognise the controls are improving. I think that's really important. But we're not there yet. And that's the link back to the risk item where governance. I think we have to be a bit cautious about putting governance down in the risk register yet, because there's still an awful lot for us to do. And Gareth, hopefully, because I didn't answer your last question about the finance risk, we will see we're still holding a lot of finance risk, including the cash risk, which I agree with. So we've done a lot of draconian or tightening or whatever you really want to call it. And I think the learning is 3 things for me. One is we started at this position a couple of months ago. Is this quality or money? It's got to be both. And we've been working on trying to get that message across. The culture of expecting more money to come. We've been working on that, very clear messages, and I'm very pleased with the way in which our most senior leaders in the organisation are understanding this and starting to take that into account. So a bit like Mike's spending it all at the end of the year, that's a culture that we need to move away from. And then the final thing is we have a lot of money. Yeah. We have over £2 billion, £500 million increase since before the pandemic. 2017-18, if I go back to the reference year.
18-19, yeah.
18-19. We've got a lot of money. It's about how we use that to improve value for people. So that would be my sort of overview, really, if that's okay, Chair.
And out of all this can come that financial discipline we're talking about. And it's not about, you know, saying you can't spend money. It's about linking investment and expenditure with outcomes. You know, that's what it's about. And all activity should underpin that. Right, we've had a very good discussion. So, pawb yn hapus I dderbyn adroddiad yna ac diolch am y gwaith sy'n digwydd. Diolch mawr iawn ac gai diolch I cyfeillion llais am byddwch chi'n gorfod gadael rwan. Diolch mawr iawn I bawb am y gwaith ar y adroddiad yna. Dyn ni yn rhedeg yn hwyr, dyn ni ddim yn bell o fod yn 50 munud yn hwyr. Felly ymlaen ni ar eitem 3.2. Adroddiad ar berfformiad integredig ac eto, dyn ni wedi derbyn papur, bydd ddim angen darllen y papur, ond nodi unrhyw materion. Is there anything you want to highlight for us, please, in that report? Integrated performance report, yeah, great.
Diolch, Chair. Yes, so if I may just take a few moments to introduce it, and then I'll hand over to colleagues and they'll take you through relevant sections, just a brief highlight from each one. So first of all, the report is still under development, of course. So we recently signed off and supported our performance framework, and we are delivering and developing this report through effectively the Integrated Performance Executive Delivery Group and onwards through the subcommittees of board as well as the health board. The report itself has a highlights page of 4 quadrants, 1 page that effectively captures people, quality, workforce, finance and performance. So effectively within those 4 areas, there is a highlight position of the key areas of concern and also key areas of delivery and support and actual success. The report then goes on to exception report base and then contains, subsequent to that, all of the reports. We have moved into statistical process control charts, so SPCCs. And apologies, members, we are trying to get those training sessions in for people to develop. So it effectively just reports performance on a spectrum, but it tracks historic levels of delivery. So are you outside a normal range of variation in performance? That's what an SPC chart does effectively, rather than just have a green or red. So if you're above the line, you're green, the next month you're below the line, you're red. What it does is says there's normal variation that will occur. And then once you set those normal variation parameters, if you go below or above that, that's when it flags to committee that there's an issue that needs to be addressed. And also what it looks at is 6 points of relevance. So is there a trend of improvement or a trend of deterioration? So it looks at trends of significance as well. So it's far more informative rather than a knee-jerk up and down. It effectively gives you those parameters and those ranges that say that's a safe range. Outside of it, committee members need to be aware of. But we will look to get those development sessions in the diaries so that board members, there's lots going in, unfortunately. And I think the earlier discussion was the demands on IAMS is quite significant at present. But I think as this report is developing and utilising, it is standard now across pretty much the whole of the United Kingdom, not just Wales, actually. So we will get that training session in. I think it is really important. And the second, the only other part I want to just mention is I think there's a massive role here in terms of subcommittee development and escalation of those reports. So the escalated section through the relevant subcommittees and subcommittee chair, I think probably is an evolution of this report. And that possibly is a way that we can focus on the things that the committee feels are really important through that escalation phase, and we've aligned to the earlier conversations that we've had. So we're looking to develop it that way. But also bring in local metrics. So these are very much nationally driven metrics, and we want some metrics that are meaningful for us. So we had a really detailed conversation in integrated performance. We are going to develop those local metrics And certainly when we commence in the new financial year, we'll be reporting those through subcommittee. And then it will be even more important for us and through subcommittee to make sure that escalation section of the report is very focused on the areas that subcommittees feel that assurance is further needed and further interrogation and health board oversight is required. So that's the kind of introduction to where we find ourselves. At this point, if I may hand over to Adele, and we'll just talk a little bit about performance.
Thanks, Russ. Yeah, so I'll take the report as read, and obviously there's a great deal of detail in there. At the top of the summary report, there's some escalated areas which the board are fully cited on, and there's detailed discussions which take place as part of the subcommittee structure in that regard. One thing to point out, we're obviously talking about access and performance here, so very much talking about percentages and numbers, full recognition. These are individuals, these are people and families, not underestimating the impact on those. The thing just linking to Carol and Russell's point on the discussion previously on finance, we've been in a similar position with access and performance and activity as we have on finance over the last 5 to 6 months. A journey in terms of increasing and improving focus, grip and control to try to improve things now in terms of delayed waits, bringing waiting lists down for our patients. That is not the sustainable way to do it. So we've been running that in parallel. It's a more expensive model, as we know. So we're fully cited, and we have been working, we continue to work in parallel, workforce planning, quality patient safety, performance, access and finance. The answer is in system-wide change and sustainable services. So it's just to note that. What you will see from the report is that we are making progress within the planned care space. We've made significant progress in terms of our extreme weights. We're at 187 over 208 weeks at the minute, and they are primarily and will be at the end of March. Any breaches will be in relation to orthodontics and Maxfax patients. We've got a plan in place to eradicate others. As we know, orthodontics and Maxfax, we've got particular challenges working with Royal College, working with South Wales networks, Welsh Government and other NHS providers across the border to try to find solutions for this, so that work continues. We've made significant improvement on our 156 weeks and our 104 weeks in planned care, and we continue to move in the right direction in that regard, which is really important. However, it should be noted for the board that in relation to 104 weeks, the target was to referral to treatment 97% of our patients by the end of December 2023. We actually hit, it was 95.5%. So we were 1.5% off reaching that target, but it has been acknowledged by Welsh Government colleagues that we are making progress in this space. Still lots to do. The particular areas of concern, we've discussed cancer previously. And I know the board prior to this, we were having discussions about an anticipated significant deterioration in cancer performance associated with dermatology. We work together with our clinical colleagues and Llais are involved in these discussions as well with us in terms of our short-term immediate plan. And I'm pleased to say that elements of that are being delivered, and we continue to report the best cancer performance in Wales. That's not good enough. League tables we can all debate. We're running just under 60% at the minute. That is not good enough. But the deterioration that we thought we were going to experience, we have now managed to avoid. Risks are still significant in dermatology, and as you know, we're working through medium and long-term plans. The three core issues for me in this space are ambulance handover delays, which we continue to move in the wrong direction in terms of ambulance handover delays. We had the Urgent Emergency Care Board on Monday this week, which I chair, and we've agreed as part of the 6 Goals programme for Wales that you'll be familiar with, recognising the answer for this sits in system-wide change. We agreed 4 priorities. And those priorities are same day emergency care, which we have in our 3 district general hospitals, but really learning, sitting back, reviewing, and NHS executive colleagues are going to support us with a review in February, clinically led review of what we can do in terms of same day emergency care. Our review of our urgent primary care offer at the minute, is that the right model? And again, sitting back, reflecting, if not, what is the alternative? I'm progressing that very quickly. Pathway of care delays. These are our patients who are medically fit, clinically optimized, don't need to be in our hospitals, and are there for a number of reasons, including assessment delays. So in there, you'll hear me referring to trusted assessor models. How can we get our assessments done in health and social care? Yeah. They're the 4 priorities, and what we've agreed as a board, the rest of the work doesn't stop, but we have to focus on these, everyone in partnership, get behind and deliver change in these areas. The other 2 things that high risks are, and you would have picked this up, delayed follow-ups over 100% of the target date. We are moving in the wrong direction on these. To a certain extent, that is, I use the word inevitable, but it shouldn't be, because we have prioritised first out patients and the risk there. We need to measure the system and get the services right, that is not one or the other. So is that a knock-on effect? We have got a follow-up transformation programme. It is multifaceted, and we're looking at things like validation. We agreed previously that we would be validating 47,000 open pathways. We validated almost 35,000 of those. See on symptom. This is working in a lot of specialties where patients are discharged, but they know they can access, if required, and in a timely way, that follow-up. It's not just a routine, you must come back. And also, where else can we provide those follow-ups? It doesn't have to be in a hospital setting. So that's the focus there. And last, but by no means least, something that Nick, Angela and I are very much focusing on is the ophthalmology R1s. And these are the most clinically urgent referrals. And we are moving in the right direction in terms of 56.3% of our patients compared to 49% the previous year are being seen within their clinical target date or within 25%. But again, not good enough. Farm reviews, that clinical triage, and the system change required now, primary care services across North Wales. So they were the main risks, Chair, that I wanted to point out.
Great, that's really useful, and a good summary of those areas of concern. That there's some good work happening, progress being made, although it's not always rapid, of course. I understand that. Everybody on. Anything else, Ross?
So I'll bring George in if I can.
Thank you, Russ. So from a workforce perspective, I'm looking at the data on page 11.5. The data shows the in-month position, and I think, as Russ alluded to, we're sort of working on the development of the report, and would want to bring you the sort of rolling trends in the next version of the report. So just to give you some perspective on that, so performance appraisals, we are ranked 4th within the All Wales system, and to put that in context, that's a 3.6% improvement in the last 12 months of people undertaking performance appraisals. In terms of sickness absence, we're sort of in the middle, we're 6th, and we've achieved a 0.6% reduction in sickness in the last 12 months. And in terms of nursing and midwifery turnover, we're actually 3rd in Wales, and we've achieved a 2% reduction in turnover in the last 12 months, which is really, really good. I won't touch on agency because Russ has already done it, but I think you'll see from the diagram there's a steady reduction in agency usage. I think improvement wise, the sickness is where we need to improve, and I think that's already been picked up in the People and Culture Committee, so that'll be part of that agenda going forward. Thank you, Chair.
George, very useful. Anything else, Russ?
And finally, just the quality, but by no means least, I believe Nick Egan.
I'll do it to preserve Angela's voice. I'm happy to take any questions, but perhaps just to highlight a few areas of particular focus. Firstly, will be around infection prevention, huge amount of good work going on. Absolutely no room for complacency, but particularly at this time of year, rightly an area for focus. And perhaps on a parallel, vaccinations, you'll see a few reds on the report in front of you. We're not alone in Wales or in the UK, but particularly around measles. That of course is a very real concern and one that will continue to remain at the front of our minds with the MMR vaccination use. The coding sounds very dry, and why is it important? Because it tells us our business, it tells us what we're doing. That helps us understand the quality of our clinical audits and shows us where our quality areas are. And Dylan and colleagues are all working together to try to understand how we can improve that. And Dylan in particular, bringing our attention to that important area. But perhaps Chair also to highlight that more KPIs on the way that will give the board really appropriate visibility of where our key issues are, possibly taking some others out in order to ensure focus. But those KPIs including more primary care, so we really understand the whole of our integrated healthcare system, not as perhaps you could argue today, is more in certain aspects, particularly within our secondary care environment.
Great.
Open to questions, any questions?
Great, diolch yn iawn, adroddiad cynhwysfawr iawn ag lot o fanylion yna sydd yn darlunio yn perfformiad ni fel bwr iechyd, felly yn ddiolchgar iawn am yr adroddiad. Unrhyw gwestiynau sylw dwi'n mynd yn drefn yma. Rhian, Mike, wedyn Gareth a Claire.
Yeah, thank you very much. I mean, it's good to see that there is improvement in so many areas of work. I suppose the only thing I want to say about that is referring to a discussion that was earlier this morning. Each figure, each graph, each something represents people. Yeah. And we must be mindful of how we're managing the hopes and expectations of those people behind all the data. Yep. And it doesn't come out in this report. I'm not saying it's not being managed, and I'm glad, I think, I couldn't quite pick out what Adele was saying, but you did say something about managing people, and it's down to the communication thing again, isn't it? But I just wanted to set that, in this context. And then the other thing I just wanted to say, and there's no answer now, but we're starting to talk about transformation, aren't we? Mm. I know over the years, when transformation is mooted, people want more money to do the new thing while they're still doing the old thing. And it's got to be that seesaw, isn't it? You've got to phase out something in order to bring something else in. And it's very difficult to manage it. And I noticed that somewhere in the narrative, IHCs are saying they can't release more savings, etc., without transformation. And I just wondered how transformation as an area was being dealt with and understood. I mean, I don't expect an answer now, but it's just obviously, but it's just something to that we will get to grips with over the next months and years.
Diolch yn iawn, Rhian. Pwynt da. Mike, nesa?
Yes, just a general question really. I don't know if it will impact on performance. I've had some concerns expressed about availability of medicines, and I've tackled local chemists about it, and it is a reality. Yeah. Is it affecting our hospital? That they're trying to mitigate by maybe handling the person with maybe alternatives, but they're not always available. What's the general position, please?
Ie, ma' na brinder rhyngwladol ar un y ddau o bydd y gynieithion ond ei adael i bobl eraill mynd i'r manylion yna. Gareth, dwi'n meddwl, wedyn Claire, bring you in later.
I'll try to keep it reasonably short. I mean, first of all, I want to welcome the continued efforts to improve the presentation. I think we're making progress. And I like the summary report, and I particularly like the emphasis on being open about our performance, because as I think we've acknowledged around this table, if we achieve one thing, it's got to be that the staff particularly feel confident about telling us where the problems are so that we can do something about them. So I think this is absolutely essential. It's also open us obviously to the public who, after all, we're here to serve. So and I also welcome the fact that in some areas, obviously, there is this definite improvement. But when you look at the section on page 9 or the NHS performance dashboard, it does show, you know, that we're still adrift on some really important areas. And I'm glad Adele touched on the handover delays because, and you know, it's easy to be influenced by the last thing you read, isn't it? But there's been a little bit of coverage recently about the fact that in Cardiff and Vale, they have reduced ambulance delays, for handover delays very significantly. And there was, I link this to a response that the minister gave in the Senedd, which showed that Cardiff and Vale is the only one of the health boards where presentations at emergency departments are lower than they were before COVID, whereas in others, including ours, they're significantly higher. And that was linked in the ministerial answer, possibly. This may well, because I'm not naive, maybe it's sort of lobbying, but that Cardiff is being experimenting with this health pathways, which I think is exactly one of the diagnostic tools that you talked about in primary care. So it aids GPs, and I think to some extent gives them confidence when they don't need to send people to emergency care. And whether it is related or not, I would like us to have a serious look at that. I raised this, and I'm not being, but a bit of a sort of brush off. Nah, I don't think it's anything to do with that. Well, it may well not be, but given the situation we're in, and in addition to all the things which Adele has highlighted, because I don't think the answer to say it's all the fault of primary care, it's obviously not. But we should look at that, if that might be something that has worked in Cardiff and Vale. Because it is all a system, isn't it? As we said, it's a systemic thing. So that's my little plea on that one, and I'm not receiving any payment from the company who are obviously operating globally, but also I think elsewhere in the UK. I was glad Nick picked up about primary care because I'm concerned that we don't have any particularly meaningful indicators that help us on that. And then just a final sort of rather nerdy point. I know I look at Carol here because she likes nerdy points. That I really think it's important when we have the comparative data with Wales, but I'm worried that it's not always what it seems. So I mean, Carol and I have had a discussion, and I know you have a concern about where there are numbers because of the scale of Betsy, but that's not the issue. It's actually that when what you're looking at, the desirable is being highest, then that's one thing. So cancer rates, we're first. And when you look at the figures, we obviously are first, but some of the others, because it's inverted, you know what I'm saying, but it's quite important. So take where we're saying we're doing well on agency spend, which I believe we are. If you look at the performance, the performance data late, we're ranked 10 out of 12 in Wales, but that's because we're 10 out of 12 in the percentage of our spend that's on agency, i.e. we're the third best, not the 10th worst. So we just need to make sure we explain that in a clear way to ourselves as well as to the public. So that's my last point. Thank you.
Diolch yn iawn, Gareth. Claire, dwi'n meddwl nesa?
Thanks, Adele, you kind of went into a lot of detail on a lot of things I was going to ask, so that means I won't ask many because I understand what some of the plans in place are for some of the really critical things. But the one you didn't cover was around neurodevelopment. And so I guess I was really concerned to read in the performance report that kind of target around 80% following assessment should wait less than 26 weeks. We're only at 26%. So is there a plan around that and what are we doing? And then I think the other thing was just to say that the style of presentation is really helping now. So the 4 quadrants I like, and maybe linking it back to conversation on risk, we could be doing a deep dive in a quadrant. So obviously committees need to then look at all of the areas that are relevant for their accountabilities, but at board level we could be doing a deep dive, one at each meeting. And then I had quite a few things to say around complaints and learning, overdue investigation, but actually they're in the quality report as well, aren't they, in the next one, so I'll say so neurodevelopment will be useful.
Great, diolch yn iawn. So, cyn I fi ddod â Carol yn ôl, Jean?
Yeah, I just wanted to pick up then about the vaccination
partly because I've got the most up-to-date figures around flu vaccination. We continue to improve. We're the second best in Wales in terms of the over 65 vaccination against flu, and the third for the under 65s. But no room for complacency. And some of you may know that in the northwest there's really significant increases around the flu. In fact, I believe the Countess of Chester has stopped all visitors as of today because of that. So again, a plea about actually making sure that everybody you are getting them to that message about getting vaccinated if they're at risk or over 65. The second is the measles. Again, we are monitoring this really closely. Really good news that our local health protection team, the funding is being agreed that it will become recurrent from next year, and they have been working up the plans for if we did have an outbreak, and we're working with Public Health Wales. But it's a really significant risk. The West Midlands, what we are seeing is nearly a third of children who get measles are being admitted to hospital. So again, a real plea as a message as a health board about that real importance of children getting vaccinated.
Yeah, and some of the work around that, one of the challenges is, this is the problem with percentages when I think somebody made the point earlier, well, 80%, okay, but the people, the more significant are the 20%. So it's something that we need to consider. And the link, by the way, everything about the way NHS Wales is measured drives us towards league tables, drives us towards who's the first in Wales and so on. Well, let's decide what our ambition is with some of these things and measure ourselves. What should we measure ourselves against? Is it an all Wales? Is it an international? It doesn't have to be tied down for us to say, okay, we're aiming to be the best in Wales. Of course we should, but actually, are there international comparisons that will help drive performance, not just being all right, we're 10th or first or whatever on an all-Wales basis. So something to consider. Right, I'll bring Russ and Adele and Carol back between the three of you to respond. We're running really late, so if I can just ask you to be as succinct as possible, so there's some important points raised. You can decide between the three who's going to say that.
First, go first because I'll keep it tight. And Gareth called me a nerd, so
that's a term of phrase.
So he knows I like the data. So and I completely agree. And I'm going to write to a Welsh Government official to ask for real consideration of the reports. Because we often have in the benchmark information, it's judged on number. Now we're always going to be high because we're the biggest health board. So it would save me from doing my calculations as to what proportion that would be. When I did go through all of the measures that are in Welsh Government, there are a number we are meeting. So I think we should recognise that, and there are a number that we're improving, but we've got some very tricky ones, very deep rooted. If I could just mention neurodevelopment, because I've raised this on a number of occasions with Welsh Government colleagues. This requires a national solution as well as local solutions. There is no health board getting anywhere near the standard here. As one health board that sort of stands out, but they are only achieving 54% rather than 80%. And I know that health boards put a lot of effort into that. So there are some big system issues that relate to social services and education and how we really tackle these things. So there's that. And Gareth, we will look at the health pathways, referrals, Cardiff and Vale. There are some very differing opinions as to whether you can draw a direct line between those two. So the population is different. But certainly we have to have a look at what are the options other than referral into a hospital. And I think we're really quite secondary care focus is my view, but we've got so much potential in primary and community care. So there's that one, and then just the last one from me relates to really how we can think about we are moving our maturity, making data count. I think I mentioned it to people the other day, using data, trying to present it, getting underneath what it really means so that we can focus on the big tricky issues. So I'll leave that.
We are. Russ and Adele.
Carol's covered the 2 points. And I went, just one thing on
Yes.
Cardiff and Bay. We've had 2 sessions now, a wider session where they were both in and an executive team. So that's been going on for about 4 months. So we are looking at
Great.
Cardiff, but the baselines are very different.
Yes, yeah,
Where we started.
appreciate that.
That's it.
The important thing is that we're alert to what's
Yeah.
happening elsewhere, and that's really helpful. The connections you've got, really good, and we're going to hopefully continue those connections when you go back to a previous role as well. So, you know, really grateful for that. Russ, anything to add?
So I'll only add by saying we'll look to the metrics so it's very clear if it's a positive or not. They are the reported Welsh Government or Wales metrics. So we'll still have them standard, but we might have them agreeing to, you know, maybe pull a code of just so this is a positive thing or not. So we're very clear. In terms of the medicines and availability, we'll take that outside with myself and Nick, and we'll just get back and make sure members are aware. I'm not aware of any medicines availability, but we will get back to you on that particular issue.
Yeah.
And I don't know whether you want to mention anything about the neuro development.
Carol.
Oh, did you?
Yeah.
Sorry.
That's right.
Well done. Absolutely. Thank you.
Diolch yn iawn. Felly, diolch am y holl waith yn bawb. Rhai arwyddion calonogol, mae yna rhai heriau yn parhau. Wrth gwrs, pawb yn hapus i dderbyn yr adroddiad yna a'r perfformiad integredig. Diolch yn fawr iawn. Ymlaen yn ni, yr eitem nesaf fel dweud, ni yn rhedeg yn fwy am ddeheiriadau am hynny. Adroddiad 3.3, adroddiad ansawdd, the quality report. I think, Nick, you taking this in place of Angela.
Thank you, Chair. And I will just, if I may, focus on 2 or 3 areas of particular importance. One to flag as a topic for much future discussion, I suspect, is the quality management system. Really high on our priority. A very useful discussion I felt yesterday for the exec team with Improvement Cymru. And a QMS, a quality managed system, is around having a consistent approach to quality. Discussions needed around what quality is, because it's probably not traditional quality as we perhaps describe it sometimes in this board, but more far-reaching into quality, into every area that we work. Looking for consistency, looking for our reassurance around the effectiveness of what we're doing, looking for our learning, and that being done in a systematic way right at the heart of our business. Very easy to put in a paper, extremely hard to do in practice. And learning from the best, both within Wales and across the UK, and perhaps further afield as well, to understand who's done it at a scale that we would need to do to make it meaningful within this health board. And I think it's something we're discussing in a board workshop in February, and again with the senior leadership team next week, I think. So much more on that, but it really is important, not just because it's a requirement for us under our duty of quality, but something we want to do and we need to be doing. A glimpse in the report at the changes to the quality dashboard, and the clue is in the title. We've just looked at the integrated report and more of the quality going into that integrated report again. So we're seeing that whole picture of how our business fits together. A particular area of focus for us is both the timeliness, but also the quality of our investigations, both in response to incidents, but also, Claire, as you're about to highlight, in response to complaints. And we need to, and the quality management system, I think, will actually help us with this, have that consistent response, consistent standards. It's also, I think, going to be informed by the work we've already touched on in this board around the review of the outstanding coroner investigations, whereas we look at historic investigations that have sometimes been done less well on a live basis. We can feed that understanding through to our current investigations. There are some particular challenges around the complaints where we've had a recent flood of it's good to have received them because we understand what's happening, but there has been a particular issue around one of our services that's led to that. But we do need to be able to respond to that in a more timely fashion. I would like to highlight actually the work, the HIW inspection of Morva in Llandudno. Isn't it wonderful when you read that our staff are, and it's been a thread through the patient story and other things, really listening to patients, talking to patients, compassion is there. It's not just the transaction of healthcare, it's the care of healthcare. And wonderful to see through an area that has had its difficulties in the past, really being commended for the work that they're now doing. And perhaps I'll finish with the patient experience, because again, that is really not just collecting. I'm not suggesting that we do just collect it, but much more work needed as we begin to collect that more consistently and more widely across the health board, feeding that into our response, the prioritization and planning of our services, a part of our quality management system. Because I think in the NHS, we're not alone in at times the patient experience sits alongside other quality work, and we really need to integrate it and bring it all together. So very brief summary, Chair. Happy to take any questions, as I'm sure will be Angela, as much as she is able. Gareth.
Great, diolch yn iawn, Nick, that's very helpful. As you say, our session as board development next month, the end of the month, next month, will be an opportunity to give more focus to this work as well. Cwestiynau neu sylwadau? Dwi'n gwybod bod gan Claire question. So Claire, this is your moment for the question.
I might not ask what you think I'm going to now. I suppose that I feel overall we are seeing some green shoots in terms of, I guess, a real focus on wanting to learn from incidents faster and get that embedded more broadly. But we still obviously have some real challenges around our timeliness of responding to things and really embedding and learning. Yeah. It's good to see some of the deep dive work on complaints and an honesty around some of the challenges or the quality of some of the responses to things, which is what's resulting in delays. And we've got to get the quality right first time, but again, I would still prefer us to get the quality right and send out an incomplete response or a wrong response to somebody. But there's a couple of things reading through the report that kind of I thought, oh, I've never heard of that before as an issue, never heard of that, which is a medical gas, there's massive obstetric hemorrhage review, which I did have to Google. I got the obstetric, it was massive, I wondered. But anyway, what I feel we're unsighted on as a board is what's coming over the hill around quality. So the report very much talks to how well we're doing on responding to things that have happened in the past. But I was in Mike's shoes between January 22 and July 22, and I didn't know that at that time we were having some challenges around the numbers of massive obstetric hemorrhage reviews in aspartic fluid. And I think we need to be cited on those things. So if there are things going on now in our services, we ought to know about them and know what's happening on the ground right now to address some of those things. So I can see some progress, but that worries me about, well, because we're kind of looking so far into the back most of the time and into the past. So I guess that, how are we going to get to a place where?
Diolch yn iawn, Claire. I'll bring Angela in a minute, but I'll wait in case anybody else unrhyw sylwadau, unrhyw gwestiynau pellach. No. So, Angela, over to you if you're able to, please.
So thanks for the reflection of that, and I completely agree with you. I think moving from this report point of view, we're evolving.
Yeah.
So what the quality data we picked up as part of the integrated report, we'll have our dashboard in the background, which needs a committee. But they'll be able to utilise that. I think we haven't necessarily in the past brought those issues to the attention. That's why we wanted to include them in this report and going forward. The massive obstetric hemorrhage was because we'd had a number of cases that we wanted to do the review on and make sure it's very needs. There was another issue that I asked a couple of months ago for a review to be done because I had some intelligence from external stakeholders. We've taken that review around neonatal care and there isn't anything there. That's going to the Air Quality Committee as part of the before, it's gone up through QDG, it will come through to board as part of quality. And what we're trying to say in the future is, this is about our quality, this is the narrative, this is what we're doing, this is what we found, this is what we're improving. And the actual how many complaints are overdue, this and this is data, and it's about the background really. So the report's evolving because it's getting the teams on board to understand the shift in what we want to report, how we want to deliver. The quality of the investigations has improved since I was here. The timeliness has improved. We've reduced the backlog significantly, apart from the trouble that we've had with public services. It's a review of how we're managing complaints, how we're managing investigations is part of our critical governance review at the moment. So we'll see a change in that. And I know it's only a small step change, but to get from 19% within the 30 working days to this time 42%, 39% is a massive difference compared to looking at. So I think we're just on a journey, but I would really welcome, sort of conversations with colleagues around how we can make this alive, this quality.
And there'll be a great opportunity at the end of the month, as you say, in the board development session, and we really hope that your voice is fully recorded. Yes, no, definitely we wish for that. No. So Carol, a comment before we close this item, please.
So I think the development design of our quality management system for the organisation, and possibly straight beyond that, working with others, is absolutely critical. Because Clay, I want to know, we need to know, where are our problems? Where are they? Not we find their problems out after, something terrible's happened. But number one, where are our problems? Number two, do we know what good looks like? Number three, we've got the capability to get there.
Yeah.
That's what QMS will help us to understand, so that we're ahead of it. And some of the problems are not at the sort of individual level, they are the system design issue. So if we think one of our quality problems is actually we have too many people who end up stuck in hospital for way too long, and their outcomes and their experience are affected by that.
Yeah.
So how do we plan our services with quality in mind? And that's what we've not been doing particularly well in the NHS, I would say, but here it's quite reactive. So I think, great conversations yesterday. There's going to be great conversations next month. I'm sure we'll aim on getting that framework and system in place.
Diolch yn iawn. Reit, nawn ni ddod ar bwyten fyna I ben gyda diolch, ac dyn ni'n ymlaen at mwy o waith yn y maes yma, fel dyn ni wedi nodi chydig o weithiau ddiwedd mis nesa. Pawb yn hapus I dderbyn yr adroddiad, os yw'n gweld yn dda. Ymlaen yn ni felly I eitem 3.5, a wedyn eitem 3.6. Helen, diwddariad ar ymgysylltu, a wedyn adroddiad partneriaethau. Dros at y tîm.
I don't want to dwell on the content of these reports, because I think everyone can read them and they speak for themselves. I thought what might be more helpful is to draw attention to the work that's going on now to take us forward around engagement. And I think you can see that over the last 6 months there's been quite extensive touch points with patients, families and carers and stakeholders as well. And we, over the last, it must be 8 or 9 months, have been working with Kath Broderick, who's an independent advisor to the board. And she's been doing a very deep dive into engagement across the organisation. And there is a report that the board will be very interested in. And I think we are trying to find a date so that you can look at that in detail. That report points us towards some of the gaps in what we're doing already, as well as some of the areas where we are working quite well. And the work now is very much focused on how we can work together across the different teams and services and parts of our organisation that have touch points with patients, carers and families, to look at how we can have an organisational approach to doing that, so that we start to embed it in a very methodic way across our services, so that we are, all the listening that we do, all the insight that we gather is pulled together in one pot, and then enables us to move forward in improving our services. So that work is underway, and we start at the beginning of next month with some key people to start to develop that. The second area that I wanted to highlight is around the work of the team that I look after, partnerships, engagements and communications. We are very much focused on shifting our energies and efforts into engaging. So we do communications very well. Where we need to expand and get much better is around engagement. So our digital engagement team are taking much more of a lead around planning, thinking about how we work with the channels that we've got, channels that we are trying to develop. So I'll give you an example just to put some colour into it. We are gathering people's email addresses so that we can bespoke tailor information that drops straight into their inboxes, rather than relying on, for example, the mainstream media. And we are getting ahead of where we know there is a news item coming up, talking with our stakeholders in advance of that news item, so that we can shape the narrative and that we have more control over how Betsy Cadwallader is portrayed, because there is a lot of good to be told. It gets lost in the melee of the headlines often. So there's work going on in that area, and there's work going on, as you'll see, in connecting our senior leaders with communities. And also got the community conversations coming up. We have a couple in the next couple of weeks, and I know some of you will be joining us at those. So our efforts are very much around front foot on engagement and doing a lot more of the work that you see in this paper. I'm happy to take questions.
Question first, second.
I've just got a quick question, Helen, if that's okay. You've noted here that there's been engagement on developing the breast cancer pathway redesign and the gynecological cancer pathway. An engagement event was held with a new name staff. I just wondered, were citizens using that service involved in that pathway redesign?
Yes, I believe so. Some of this is slightly outside of my realm of touch, so I do rely on the reports that come in. But yes, cancer is definitely one of the areas where we know that happens. That's the whole point of the work, is that we have to do that everywhere.
Yeah. Tria?
Yeah, just very quick. Interesting, you've identified all different sorts of engagement, and it's something that it's come up in QSE really, from various feedbacks. The question is, so what has changed in the light of receiving that feedback? And I think that's the additional layer that possibly needs to come in due course.
Okay.
Dwi'n meddwl mae'n gysylltu mor bwysig wrth gwrs i ni fel hwn. Y da a'r drwg, dwi'n meddwl bod da ni'n gorfod bod yn fodlon clywed bob dim, ond dwi'n meddwl sydd angen sylw, a dwi'n meddwl bod hyn yn wir mewn ymgysylltu ar draws dim jyst y bod iechyd, ond yr sector gyhoeddus yn fwy gyffredinol ydy sut da ni'n cael pobl i ymgysylltu i wneud rhywbeth weithiau ar wahân i wneud cwyn. Cos mae pobl yn aml yn mynd i ymgysylltu oherwydd mae gennyn nhw rhywbeth pwysig maen nhw eisiau wneud cwyn amdano fo. Weithiau mae eisiau troi hwnna i ben fel bod ni'n gallu cael pobl i ddod i mewn hefo syniadau, hefo ffordd sut allwn ni wneud yn well. Math o beth yn hytrach na bod o'n gwyn penodol.
Y bwyd da, dyn ni eisiau bod yn sefyllfa lle gall pobl gyfrannu at helpu ni siapio ein gwasanaethau mewn gwirionedd. Ac mae gen bobl beth i gyfrannu at hynny. Helen, do you want to come back on
Thank you very much. Please, board meetings are a great opportunity to showcase things that are happening, but please contact me all the time with your thoughts and ideas as we shape the way forward. That'd be really helpful. Yeah.
Diolch yn iawn. Pawb yn hapus i dderbyn y droddiad yna. Diolch yn iawn am y gwaith, ac dych chi wrth gwrs yn gwybod am y digwyddiadau sydd yn ymlaen dechrau wrth nesa, dwi'n meddwl, mis Ionawr yn Ninbych, mis yma, a wedyn cyfres y cyfarfodydd ar draws yr holl ardal. Felly, ydyn ni edrych ymlaen at hynny. Diolch yn iawn am y adroddiad a diolch i bawb am y gwaith ar hynny. Adroddiad partneriaethau, Helen, rhywbeth i ddeud, rhywbeth mwy i ddeud am hynny?
As you will see, it is a summary of conversations that have been happening between colleagues in Betsy Cadwallader and in our partnership forums. Those notably being the Regional Partnership Board and the Public Services Board. Key items that I think have been discussed in the last couple of months include dementia, autism, and some of the strategic capital planning and areas of that note. I do know, and Carol may wish to say more, that there is a plan to review the partnership space and to look at how we can make improvements in that area.
Rhian, question?
Yeah, maybe I'm thinking about different partnerships, but I just wondered where our work with local authorities regarding delayed transfers of care fits in. It's a different forum, presumably, is it?
It's the regional partnership boards generally, isn't it?
The
But, you know,
RPBs,
and
so that's
the
not covered in here.
groups underneath the RPBs.
Yeah.
Okay.
Diolch yn iawn. Unrhyw gwestiwn gan rhywun arall?
Ella just sylw, yn ôl i pwynt Clare, mae'n dangos bod yna gydweithiad yn mynd ymlaen ynglyn â'r maes neurodiversity a neurodevelopment, yn lleol. A mae hwnna mewn partneriaeth sydd yn digwydd ar y lefel yna, ond yn gweithio'n weithredol. So yn gwneud gwahaniaeth i plant eitemau yma yn Gogledd Cymru.
Diolch yn iawn. Pam yn hapus sy'n erbyn y droddiad yna? Ie, diolch yn iawn a diolch eto am y gwaith ac oes mae'n adolygiad ynglyn â partneriaethau lle mae cyswllt ni, pwy sy'n mynych chi cyfarfodydd, lle dyn ni'n adrodd a beth yw'r deilliannau o'r gwaith ac yn y blaen. Dyn ni'n edrych ar hynny a gobeithio bod ni'n dod am manylion i'r bwrdd maes o law. Ymlaen i eitem 3.7, adroddiad ar weithgarwch hyd bwyllgorau ac dros y Carol please.
Thank you very much. So a brief report this time, and I must apologise. I think an errant old underpinning report has been circulated, or certainly I've got it from July. We'll circulate the more up-to-date papers that were available. So you might have had a bit of deja vu. I've read this before, you have. I just want to draw one thing out that isn't in the report, and that's that the change in WISC and EASC, so Welsh Health Specialised Services Committee and Emergency Ambulance Services Committee, is progressing, and from the 1st of April will become one single joint committee. So just thought I would flag that and to say that progress is being made. I've been involved in a couple of meetings on that, and I think it'll be very important for us to be clear about our role and our connection to that function that works on our behalf. Some very interesting things for us to look at, particularly in terms of some tertiary services that we both provide and also secure for our population. I wasn't going to say anything else.
Great. Diolch yn iawn. Unrhyw gwestiwn? Os nad oes, pawb yn hapus i dderbyn y adroddiad, sgwrs yma. Ie, diolch yn iawn. Ymlaen at adran nesa, mae yna nifer o adroddiadau fan hyn sydd gwybodaeth, ac be dyn ni am wneud yn yr adran yma ydy cynnwys yr adroddiadau, mae gan bawb gopi i ddarllen yn hamddenol, ac yna, os ydych chi'n dymuno codi cwestiwn, wrth gwrs, mae yna gyfle i godi cwestiwn. Ond fel arall, byddwn ni'n derbyn yr adroddiadau yna a byddwn nhw'n parhau yn yr adran gwybodaeth, a mae yna nifer fawr ohonyn nhw. Un y ddau ar goll megis y pwyllgor perfformiad a cyllid ac yn y blaen. Wel, o'n adroddiad fis dwytha yn bwrdd dwytha, ac wrth gwrs mi fydd y pwyllgor elusennol yn adrodd i'r bwrdd nesaf. Felly mae yna wel, casgliad o adroddi yna, ac os oes rhywun eisiau holi cwestiwn, dyma eich cyfle. Dyna ffordd da ni'n mynd i drin adroddiadau gobeithio i'r dyfodol. Karen.
Mine's just a point of clarity. At the end of the audit committee paper, it suggests we're going to have an extraordinary audit committee meeting, which isn't the case. We're going to have a discussion between audit committees. So just to clarify, there is no extraordinary.
Not a committee. Diolch yn iawn. Unrhyw arall? Mike, a wedyn Rhian.
Yeah, just with the SRG, we've got a workshop next week, but one of the worrying things has been the attendance, particularly the county councils. The chair and myself have jointly written to the county councils about our concerns. So it'll be interesting to see what attendance we get next week. I'll also remind the board that I think one of the weaknesses historically has been that the SRG's work has been reflective of stuff that has happened. So I think we've agreed that certainly we need to get involved earlier so that we can contribute. I'm sure we all agree we need all the help we can get. So I think our partners, some of them are quite valuable and be able to give us some insight into how maybe we can deliver things better.
Yeah.
Yeah.
Diolch yn iawn, Mike. Yn pwysig yna, ac mi fydd y gyfle i ddylanwadu gobeithio ar ein cynlluniau wrth yn y blaen, cynllun blynyddol, cynllun tair mlynedd ac yn y blaen, gan y grŵp rhandeiliad sy'n deilio, felly byddwn ni'n edrych ymlaen at hynny. Rhian.
Sorry, it's probably my fault. There should have been another couple of things that I wanted to stress. They're not on the items to be escalated to the board. It was just, we really want to get a push on ensuring quality indicators for primary and community care. I want the board to be really aware of that. Also, how to involve IHCs more in the quality agenda, or to see how that web works. And then the third thing really was, the diabetes pathway is very definitely on our radar. So I just wanted to re-emphasize that.
Okay. Diolch yn iawn, Rhian. Rwy'n arall? Na? Os nad oes, yna dyn ni'n derbyn yr adroddiadau yna i gyd, a diolch am y gwaith sy'n digwydd yn y meysydd amrywiol yna. Eitem nesaf ydy 4.2, crynodeb o'r busnes sydd wedi cael ei trafod mewn sesiwn breifat. Mae yma i ni fel bwrdd i dderbyn. Os nad oes cwestiynau, yna dyn ni gyd yn hapus i dderbyn y adroddiad yna. Ydan, diolch yn iawn. Eitem nesaf, eitem 5. Da ni'n dod i ddiwedd ein cyfarfod, ac un o'r eitemau da ni'n awyddus i drafod ydy sut allan ni wella'r cyfarfod nesaf, sut allan ni barhau gyda'r cynnydd da ni'n gwneud, sut allan ni weithio mwy effeithiol. Mae'r cyfarfod yma wedi, tua awr ychwanegol, felly Cadeirydd ddim wedi gwneud job da yn cadw yr amser. Ond wedi hynny, dwi'n meddwl mae yna un o ddau beth yn werth nodi. Does oedd yr eitem o gwmpas stori'r claf a'r profiad y ddinesyd wedi esgar ar lot o drafodaeth. A drafodaeth honna yn un hynod bwysig. Ac mae eisiau ni fod yn hyblyg weithio i roi amser mwyn i ni gael y gwerth allan ohono. Ond mae angen ni edrych ar agenda. Dyn ni wedi ymdrechu wrth gynnwys yr adran yna gwybodaeth yr adroddiadau yna mwyn ceisio creu amser lle dyn ni'n cael y drafodaeth bwysica. Ond mae gen i le i wella o hyd, dwi'n meddwl. Unrhyw sylwadau, unrhyw un efo rhywbeth i gynnig, lle allan ni barhau i wella, gwelwch yna. Claire, some thoughts from you on the analysis?
And kind of builds on what you said, Chair. I think it's interesting as your report, Vice Chairs and the Chief Execs are. actually they're really information items. They're really there to let us know what you've been up to. And I just wonder whether we could order those further down the agenda, because I didn't check my watch at the start and end, but I'm sure we spent more than 20 minutes on those 3 items, probably half an hour. I think that the patient story, yes, we took a long time, but I think it was important. And I thought the item where we had talking about resident people feedback, that was an important part of the agenda. So just maybe thinking about reordering those items. And I guess in addition to that, the items on, we haven't really had them before, the book partnerships, joint committees. I thought with some of those things, they get reported in public anyway. We can find the information if we want it. And some of it, I felt with some of them, I sort of felt a bit so what, because it told me what was on the agenda, but there was less information about what that might mean for me and Betsy. So again, I just think good that we know all of that and we understand the partnerships we've got and who we're working with, but perhaps have a little think about how we might make best use of our time here around those. And then just a final point, which was, I did say it in the meeting, but I think we just need to perhaps have a fresh look again sometimes at what we're asking the board to do with things. So I think if we need to be being assured about something, then the recommendation should say that, not for us to note it. So just having a little think about some of the recommendations will be useful.
Okay,
Diolch
great.
yn fawr.
Diolch yn iawn. All that was very helpful, and we will have a look at the way we order things. Rhywun arall efo rwbeth i ddeud? Anybody else? Some comments? Gareth?
Well, I just think I think it's been a good meeting. I think, there's been lots of valuable contributions. I do want to come back to this idea, and obviously we've got to make sure that we're fulfilling our statutory duties. But I wonder whether we can't have more for noting the performance, the quality, and the risk elements, and do this thing about looking at one particular area across all those domains. So the information still needs to come to us, but rather than having as separate items where we try and deal with everything and deal with it, not badly, but it's sort of like, but we have one bit where we actually try to get our heads around. I know you can say this is for board development. I don't think it is really. It's about in public discussing. So actually, what are the roots of why this isn't working? And so I just think we should have a look at that.
And I think that coupled with the discussion about what is the board's ask of committees, and what a committee is going to tell us then in terms of assurance, in terms of where the big issues are and where the challenges and opportunities are and so forth. I think we need a discussion about that as well, so that the board can be absolutely clear of its role. Okay, diolch. Anybody else rhywun arall efo rwbeth i ddweud, rwbeth i gyfrannu i helpu i wella?
Just yn meddwl bod profiad i ers ymuno efo'r bwrdd, mae heddiw wedi bod yn enwedig pan oedd Jeff ddod yn rhan o'r cyfarfod yma. Dwi'n meddwl bod hwnna yn mor bwysig, a dwi'n meddwl bod hwnna'n dangos gobeithio i'r bobl sy'n gwrando a bobl sy'n edrych a mor o ddifri ydyn ni am fynd i'r afel a claf a'r defnyddiwr fel canolbwynt bob ddim da ni'n gwneud.
Diolch yn iawn am y sylw yna, a gobeithio bod yr eitem yna wedi bod yn arwydd o'r ymgais a'r uchelgais. Gwrtha, ti'n nesa?
Just last thing, sorry. I'm quite interested in our relationship with the Regional Partnership Board, because I see that we have barriers and issues that very much links to that board in relation to how we work with other partners, particularly the local authority. It impacts with us with discharge, but it also impacts with us with safeguarding. I know a lack of an agreed approach to safeguarding across the local authorities has been an added burden, just for an example. So I think I'd be interested to see a little bit more detail on that particular, about, in our key areas, our key risk areas, what's happening at the Regional Partner Board, or is there any way we could develop that relationship? Just, just a thought.
Good point, and we'll see maybe one of the committees can pick some of that for the detail, the PPPH committee, but also maybe when we're working on partners, we can highlight a little bit about some of the successes and advantages of the regional partnership. Good point, well made. Rhywun arall eisiau sylwedd? Gawn ni hefyd wahodd y cyhoedd, os ydych chi'n teimlo mae yna ffyrdd dych chi eisiau ni ystyried i wneud rhywbeth gwahanol efo'r cyfarfod yma sy'n un gyhoeddus hapus iawn i chi gysylltu efo fi fel cadeirydd i ni ystyried hynny yn ddiolchgar am unrhyw awgrymiadau neu syniadau. Diolch yn iawn. 5.2 felly ydy unrhyw mater arall. Does na ddim mater arall wedi dod i sylw ni. 5.3 ydy dyddiad cyfarfod bod nesaf ydy y ddiwedd Mawrth, wythfed 20 Mawrth yn yr un lleoliad ac eto cael ei ddarlledu yn gyhoeddus. Dyna ni ddiwedd y cyfarfod yma, wedi bod yn cyfarfod hir, ond dwi'n gobeithio a dwi'n credu cyfarfod adeiladol a cyfarfod dwi'n teimlo bod na ffocws o'r newydd ar ein rôl ni fel darparwyr gwasanaethau i'r cyhoedd. Ac bod hynny yn rhywbeth mae gen i uchelgais i bod y gorau ac i sicrhau y safon a'r ansawdd priodol i bobl. Felly mae hwnna'n neges eitha clir dwi'n meddwl sy'n dod allan o'r cyfarfod yma. Gaddiolch i bawb mewn cyfraniadau wedi bod yn hynod werthfawr. Lot o waith wedi digwydd i'r cyfarfod yma cael ei gynnal. Diolch i Phil a Diane ac i Laura a'r tîm am sicrhau hynny. Diolch hefyd i Lowri am y cyfieithu. Diolch i'r tîm technegol o waelod calon, achos mi roedd yna broblemau, ond nathach chi ddatrys nhw. Ac mae yna ddrych o'r bwr iechyd gyfan, dweud y gwir. Nathach ni aros yn eitha cool, a nathach chi ddatrys y broblem. Felly, nawn ni gymryd y dysgu o hynny, hynny, ac diolch i chi am eich gwasanaeth heddiw. Dyna ddiwedd y cyfarfod ac yn dilyn mae cyfarfod o ymddiriedolwyr, y cyfarfod blynyddol, mae'n 10 munud i 2, dyn ni'n tua awr yn hwyr, neu o leia hanner awr o bosib, ond o bosib gawn ni 5 munud o doriad, 5 munud yn unig, dwi ddim yn amser cinio eto, dwi'n ofni, gawn ni ginio nes ymlaen, oherwydd mae bobl wedi bod yn disgwyl i gyflwyno i ni y cyfarfod yma. Ac wrth gwrs, dyn ni dal efo cyfieithydd. Helen, cwestiwn.
Just to say that I know that the people who've come to do the cardiology presentation as part of the trustees AGM have a bus outside that board members may wish to have a look at. So I don't know if that gives a bit more time. Possibly,
possibly lunchtime or after this meeting, because I know we've got